Welcome everyone for the part 4. So recalls we are discussing, we have finished 3 parts. Today is the last part what we'll be discussing. It is the part 4. Let's go into ops and gynecology. First question what we have is a 29 years old female whose postpartum has come to the emergency department with fever and fatigue. Postpartum of 7 days. What's the most probable diagnosis? We're suspecting there is much more information in the exam they must have given, because only with this exam it's difficult to make the diagnosis. But keeping in the mind it is a postmortem, more than 24 hours postmortem, means to always think of infection. In less than 24 hours postpartum, if they usually present with uterine atony or retention of products of consumption like placenta or any instrumental injuries during the delivery. What might happen that might have led to the bleeding. Post 24 hours, they're more prone for infections. So infection, you need to think about keeping this in mind and keeping the fever and fatigue in the mind. The most obvious answer will be septic shock syndrome. Now we have a next question here. We have an 8 weeks pregnant lady who has come to the emergency department with a vaginal bleed. During her last visit with gynecologist, she's been diagnosed with inevitable abortion. On examination, she is hypotensive. What you will be doing? Inevitable abortion is the one where the os is open and the products of conceptions are either in the uterus itself or not visualized. So the chances here are most likely what has happened is the product of conception is kind of stuck in the cervical os. Whenever it is stuck in the cervical os, it stimulates vagal nerve. Increased vagal tone will cause sudden bradycardia and hypotension. So the best step here is do an speculum examination, look for any stuck product of conception, remove it with an forceps. Once you remove it with the forceps, the vagal tone will come down drastically. That will improve the heart rate and improve the blood pressure. So remember, speculum examination is the important. It's a reversible cause. Don't waste your time getting an IV cannula or putting a fluid. You can reverse it immediately by doing a speculum examination. We have a 34 years old married female who has come in with an PV discharge, per vaginal discharge. It's a purulent per vaginal discharge. She says she has an intercourse with a different partner a week back, and on examination there is cervical swelling is there. What's the best management plan? So you're suspecting here an sexually transmitted disease. It can be in chlamydia, it can be in gonorrhea, or any sexually transmitted disease like syphilis. So what the guidelines suggest? Guidelines says that whenever you are suspecting an sexually transmitted disease, refer them to genitourinary clinic, also known as GUM clinic. Genitourinary medicine clinic is the single place where they screen for sexually transmitted diseases, start the treatment for sexually transmitted diseases. At the same time, they'll follow up or trace the sexual partners, call them to the department or the clinic where they will screen for sexually transmitted diseases. If required, they'll do the treatment. So GUM clinic will be the right answer here. We have a 32 years old pregnant lady who has come with an vaginal bleed. Mother is Rh negative, father is Rh positive, her obstetric history is G2 and P1. What is the most appropriate next step? Rh negative and Rh positive, whenever it is there, you need to give anti-D immunoglobulins. This is a sensitizing event, what we call whenever they have a vaginal bleed, especially in third trimester. So give anti-D immunoglobulins. There are various sensitizing events, as you can see in this. So various sensitizing episodes, you need to be aware of the sensitizing episodes. They can test you in the examination on the sensitizing episodes. We have a 28 weeks pregnant lady with a road traffic accident and brought to the emergency department. She's hypotensive and other vitals are not stable. Basically, she is hemodynamically unstable, and you have started the registration. How do you know whether this fetus is viable or not? What is the next step to see whether this fetus is viable or not? Check the fundal height. If the fundus is below the level, below the umbilical level, that means it is a non-viable. Fetus is non-viable. Just concentrate on the mother's head. If it is above the level of umbilicus, then you need to think of saving the fetus also. This is adopted from Rosen's book of emergency medicine. So everything might not go good here, but this part what we are looking for here, the initial steps are very well goes according to the UK guidelines you can follow. It's important to also know the fundal height with average gestational age. For example, if you are able to palpate the fundus at the level of umbilicus, then it might be, or most likely it is 20 weeks. At Ziphioid process, most likely it is 36 weeks. You need to be aware of this. A 30-week pregnant woman came to the emergency department with severe headache, nausea, flushing, and double vision. GP review notes were not found, and there were no reports of pregnancy follow-up. That means that she doesn't have any antenatal checkups at all. What's the most probably diagnosis here? Post 20 weeks, someone who presents with severe headache and who is pregnant, always think of preeclampsia. Again, it is a severe preeclampsia if there is a severe headache or ongoing headache, or if there is any focal neurological deficit like in double vision, what the patient is having here. It is important for you to be aware of the definitions. What is eclampsia? What is preeclampsia? What is severe preeclampsia? What is gestational diabetes? These definitions will be tested. So here the right answer here is preeclampsia, keeping all this in mind what I told you. A 8-week pregnant woman came to the emergency department with severe nausea and vomiting. She has been on IV fluids and metoclopramide has been given. Later, patient developed acute dystonia. So what is the drug of choice they're asking? In pregnancy, also the drug of choice remains procyclidine. Remember that benztropine is not available in the UK. Diazepam is not recommended in pregnant, though it can be used for treatment of acute dystonia. It is not recommended, especially in first trimester, because it causes cleft palate. So it is teratogenic. Don't use it in pregnancy, especially in first trimester benzodiazepines. A 30-week pregnant lady who has a premature rupture of the membrane. According to RCOG, which is the antibiotic you will be giving as a prophylactic? So because there is a premature rupture of the membrane, they are more prone for infection. According to RCOG, they recommend giving erythromycin. So this is the RCOG guidelines. You can go through this. Here they have mentioned erythromycin is the preferred antibiotic whenever there is premature rupture of the membranes. We have a 23 years old lady who has presented with diffuse abdominal pain on examination. There's tachycardia, systolic blood pressure, borderline, LMP 6 weeks ago. Urine pregnancy test, UPT, couldn't be done because sample was not given. So you started doing a fast scan. You visualized a Morrison spot. There is no fluid. What is the next best step? Continue doing the fast scan so that you can include the pelvis. So look at the pelvis. This is an suspected ectopic pregnancy. If it's a ruptured ectopic pregnancy, you can visualize free fluid around the pouch of Douglas or around the bladder. So you need to have that view of the pelvis. So continue your fast scan, what you are doing. Don't abruptly stop in between. A 36-week pregnant lady comes with a low abdominal pain and vaginal bleed. And in her previous pregnancy, she had placenta previa. On examination, abdomen is rigid and tender. So remember that whenever there is an abdominal pain and vaginal bleeding in third trimester, it is a placenta abruptio until and unless proven otherwise. If it's a painless vaginal bleeding in third trimester, always think of placenta previa. These are the two most commonest cause for PV bleed, that is hemorrhage or PV bleed in third trimester. We have a 31 weeks old female came to the ED with complaints of lower abdominal pain. Her LMP is 6 weeks ago. On examination, there is tenderness in right iliac fossa. Her vitals are unstable. Ultrasound shows free fluid, suggestive of ectopic pregnancy or ruptured ectopic pregnancy. What is the next step? As the vital parameters are unstable, give her fluids. After giving fluids, then you will be referring to the obs and gynae. If you directly refer to the obs and gynaes, by the time they come, she may not be alive or she might be in cardiac arrest because of hypotension and fluid loss. So giving IV fluids, buying time so that the gynae can come down and examine, or gynecologist can take up this patient to the emergency department, will be the right option. A 54 years old post-menopausal woman presents with PV bleed, most appropriate next step. Whenever there is a post-menopausal woman comes with PV bleed, guidelines suggest that you need to always suspect an endometrial carcinoma. Whenever you are suspecting an endometrial carcinoma, an ultrasound scan will be required to see the thickness of the endometrium. If the thickness of the endometrium is more, that's when they will go ahead and get a biopsy done. Should this be done on an emergency basis? No, no emergency basis it is required. It is a CA will not change in 1 or 2 days. So what you will do is you will arrange and follow with obs and gynecologist. They will arrange an ultrasound scan, or they will do an ultrasound scan themselves and see the endometrial thickness. If it is more, they'll go ahead and get an biopsy done. So the most right option here is urgent OPD referral for obs and gynecologist. Ultrasound pelvis in the emergency department itself is not an emergency thing to get it done, so it is not the right option here. Endometrial biopsy is done by gynecologists, will not be doing it. Reassure and discharge is not the right thing. You need to ask them to follow up with the gynecologist so that they can see the endometrial thickness. If required, get a biopsy done. A 36 weeks of gestational female present to the emergency department with PV bleed. Previous ultrasound scan shows her placenta was lying low. On examination, tenderness is present. So tenderness is there, PV bleed is there. As we said previously, it's abruptio placenta until and unless proven otherwise. Doesn't matter if it is low lying also, it is not placenta previa because there is pain. If there is pain, less bleed, then think of placenta previa. In female present to the ED after an unprotected sexual intercourse, which of the following statements are correct? They are asking. Contraception cannot be achieved after ovulation. No, you can achieve after ovulation. Those are the early morning pills what we give it. Ask the patient to return to ED if she develops pain, abdomen or bleeding. Yes, this is the right thing here, because still they are not 100% protective what you give this one to prevent the pregnancy. Still they might end up having an ectopic pregnancy. So ask them to come back to the emergency department if they develop pain or bleeding. Patient doesn't need additional contraception if vomits within 2 hours. If they vomit within 2 hours after taking the contraceptive pill, they need to take one more dose. ICD is the best option. No, it depends from person to person. ICD requires a skilled medical personnel to insert it. It has its own side effects. The incidence of ectopic pregnancy are quite high in ICDs. Okay, this is also a not option. They might have mentioned or they might not have mentioned carbamazepine. It doesn't matter. The answer will remain the second one. Okay, that's the reason we have put up in brackets carbamazepine here. Young lactating female complains of pain and tenderness over the right breast. Most common organism causing this. So what is happening here? This is nothing but mastitis, inflammation of the breast. What is happening here? The most commonest organism which is involved in this is Staph aureus. This can lead to an abscess formation also, so a thorough examination of the breast will be required. Now we are entering into the pediatric chapter. Pediatric chapter also includes pediatric orthopedics also. So we have an 11 years old chap who complains of right knee pain, gradual onset worsening over the time, denies any trauma. So there is no trauma at all, so you're not suspecting a fracture. But on an X-ray, if you see there is an avulsion fracture of the tibial tuberosity avulsion fracture is seen. This is tibial tuberosity what you're seeing. This is an avulsion fracture of tibial tuberosity. It is because of violent contraction of the patellar tendon. This is known as Osgood-Schlatters disease. It is a group of osteochondritis disorders. When it is tibial tuberosity is involved, we call it as an Osgood-Schlatters disease. When the calcaneum is involved, then we call it as a Serves disease. Coming up questions might come on this one also, so be aware of this. The right answer is Osgood-Schlatters disease here. A sickle cell anemia patient came to the ED with chest pain and shortness of breath. What is not included in the management you're asking? Always remember, someone having a sickle cell anemia presents within chest pain or any chest symptom like shortness of breath or anything, always suspect an acute chest syndrome, a complication of sickle cell anemia. The main management of sickle cell anemia, any complication, is giving analgesia. There is a recent RCM learning guideline. They are not guideline, it's an bulletin what they have published saying that analgesia is the most important thing what you need to remember. Out of all this, bronchodilators is not in the treatment. Antibiotics, they're prone for infections because autosplenectomy happens, and when spleen is not working at the optimum, then they are predisposed to encapsulated organisms. IV fluids might be required, they might be dehydrated. Blood transfusions or exchange transfusion might be required depending on the anemia levels, depending on their hemoglobin levels, how severe is the anemia, you might have to do a blood transfusion also. Could you please repeat again? You need to ask me which question you are asking about. A baby with suspected early neonatal sepsis, we call it as an early neonatal sepsis if they present within 72 hours of their birth. Which of the following is true regarding the sample collection? Here it is different. Only one site is enough in a early neonatal sepsis when you're suspecting. Take urine for microscopy. It's not recommended in early neonatal sepsis. In late neonatal sepsis, yes, it is recommended. You need a minimum of 1 ml. Yes, 1 ml minimum. Without doing anything at all in the emergency department, you're sending to the NICU is not the right thing. So out of these 4 options, C is the correct answer here. A 4 days old baby has distress after feeding. What is the diagnosis? It's basically, the diagnosis is dependent on the X-ray. X-ray shows bowel loops, what you can see in the chest. This is a chest X-ray. You can see in the lung field, you can see bowel loops. This is mainly because of diaphragmatic hernia what this patient is having. Congenital diaphragmatic hernia is one of the known things which can happen in, especially in newborns. A child sustained burns on both forearm and is in severe pain. Non-pharmacological treatment they are asking. Nasal diaphragm would be a good option here, but it is a pharmacological treatment. You dressing them will reduce the exposure to external environment. It brings down the temperature drastically. We are not sure about the cold compression. It is not given anywhere, but dressing them will definitely help to bring down the pain. So right option here will be 4. It's a non-pharmacological treatment what we are giving for this kid. A 9 weeks old kid was brought to the emergency department, complaints of vomiting after every feed. And investigation shows that this is the ABG what we or BBG what you got it done. It's an hypokalemic metabolic alkalosis. What's the probable diagnosis here? After feeds, especially 30 minutes after feeds, if they tend to vomit, you need to suspect of pyloric stenosis. Again, in this pyloric stenosis, the vomit contains only the food particles. It will not have anything of bile content, or it will not be greenish in color. So no bile content will be there, because bile content is secreted in the duodenum. This pyloric stenosis at the level of pylorus, there is an hypertrophy of the muscle, so it doesn't allow the food to go in, results in reflux and vomiting. In stomach, there is a lot of HCl secreted. Loss of H, that is hydrogen ions, will result in acidosis. Loss of chloride ions will result in hypocholemia. That's why it is an hypochloremic metabolic acidosis what they are given. All this keeping in mind, the most likely diagnosis is pyloric stenosis here. Mother brought an 8-month-old son after his loss of consciousness at home, lasting for less than 1 minute, but child is active, well, playing, everything is normal. The child is come back to the normal. The life-threatening event what mother is describing has lasted for only less than 1 minute, and this child is an infant. Keeping all this in mind, it goes with the definition of an brewery. A 2-year-old baby was brought to emergency department having a barking cough since 1 to 2 days, worsening since evening. On examination, there is a stridor, saturations are fine, most likely organism. Barking cough along with stridor is an diagnosis of croup. So you have in croup, most common organism which causing croup is parainfluenza virus. It's a viral infection. 10 years old limping child brought to the emergency department. He's completely stable hemodynamically. X-ray has been given. X-ray, if you compare this side to this side, you can see here there is an avascular necrosis. Avascular necrosis is nothing but Perthes disease. Age also goes in favor of Perthes disease. So this is an Perthes disease what this patient is having. The management will be just to refer to the orthopedician. You can't do much in the emergency department. We have an 18 hours old. This is not even 1 day. 18 hours old child came to the ED, brought by a worried mother. Discharged 8 hours back with icterus. Okay, next best step. So mom is worried because this is increased LOH discolorization. How do? You just reassure and discharge, or advised to talk to midlife, or get in capillary bilirubin levels? Get in capillary bilirubin levels for this patient. There are indications meant to get capillary bilirubin levels. You get it done if the kiss is less, but the delivery is less than, that is preterm, less than 35 weeks. or you have done and transcutaneous bilirubin levels which are more than 250 micromoles per liter, or this kid has presented within 24 hours of the life. So this kid has presented within 24 hours of the life, get and capillary bilirubin levels done. That is a blood test serum bilirubin level, what you're getting it done. Sustained injury, x-rays been given, they're asking for the diagnosis. Here, it is very difficult if you don't draw this line to make a diagnosis. This is known as anterior humeral line. Anterior humeral line. This should bisect at least 1/3 of the capitulum. This is known as capitulum. At least 1/3, it should have been like this to be normal. It is not bisecting. Then you're suspecting an supracondylar fracture here. So this is an X-ray suggestive of an supracondylar fracture. It's kind of similar case what we have discussed, knee pain after playing football, but there is no trauma. You can see there's an avulsion fracture of tibial tuberosity. In a pediatric age group, this is an osteochondritis, which is nothing but Osgood-Schlatters disease. Which one of the following is correct according to Slatter-Harris classification? The definitions also you need to be aware of. So there are various definitions what they are given. What is 1, 2, 3, 4, 5? You need to be remember. You can remember with using a mnemonic, Slatter itself, SALTE. Okay, so use this. It will help you to remember. Here, the right option here is option number 4. A fracture passing from the articular surface through the epiphyseal plate into the metaphysis. Nothing but this one what we are talking about. This is the right option. Type 4 definition is this. Others are not the right option. Again, we are having an supracondylar fracture here. To draw an anterior humeral line, this is the anterior humeral line. It is not dissecting 1/3 of the capitulum. Then we call it as an supracondylar fracture. So this is a supracondylar fracture type 1 because the cortex, you can't see obvious displacement and the posterior cortex is intact. A 7-year-old boy known to have a nut allergy complains of multiple episodes of vomiting with fever, chills since last 2 days. No history of travel or outside food consumption. On examination, he is afebrile. His febrile and vitals are stable. There's a diffuse erythrometas seen all over the body. Systemic examination normal. What is most likely going on? Febrile illness with a rash. Think of viral illness here. There's nothing suggestive of anything else going on here, because there is no history of travel, no history of outside food. He has not taken any nut allergies because no outside food consumption. With vomiting, fever, chills, rash, think of viral illness. 4-year-old boy brought to the emergency department after an episode of syncope, alleged history of consumption of bisoprolol. Found to have low heart rate, low blood pressure. Next best step, overdose of bisoprolol, Q glucagon. Same thing holds good for adults and in pediatric age group. 6-month-old child was brought to the emergency department by parents. They felt like child going to die and lasted for less than 1 minute. Child is completely fine now. Which one of the following is likely to be present during the episode? So for N. Bruvi, there should be an episode which lasts for less than 1 minute, and the child age should be less than 1 year. Along with one or more of the following should be present. That is, a change in skin color should be present, and I'm talking about there should be something wrong with the breathing. That is, absent of breathing, irregular breathing, or increased breathing efforts you need to see. Another thing is you need to look for tone, muscular tone. I'm talking hypotonia or hypotonia. You need to, the kid went floppy or kid went completely rigid. That might be the description. The last thing you need to look out for is the GCS, that is altered level of consciousness. Out of these options, A is the right option if you see, because the skin color we are talking about, yes, right option. These 3 are not given in the options to select it here. A 2-year-old kid brought to the emergency department with complaints of vomiting and diarrhea since 3 to 4 days. On examination, kid is having moderate dehydration. You decide to start an IV fluids. Body weight is 15 kgs. What is the maintenance fluid? Maintenance fluid to calculate, first 10 kgs, we give 100 ml. Okay, that will be nothing but 1000 ml. Next 10 kgs, we multiply with 50. So here it is only 5 kgs, next 5 kgs. So it will come to 250 ml. So if you add up, it is 1250 ml. So the right answer here will be D. We told you in the last class also, for beta blocker overdose, we don't give atropine. We start on the glucagon. If it is a child or adult, it remains the same. Explained in the last class also. Which one of the following is a red flag for fever under 5? Out of these options, B is the right option here, or right answer here. Is the grunting what is present? See, here is the grunting which is present. These are the red flag high risk symptoms. You need to be aware of this red flag high risk symptoms here. A 48 years old baby brought to the emergency department with complaints of reduced feeds and fever. You are suspecting early onset neonatal sepsis in this patient. Risk factor in early, which one of the following is the risk factor in the early neonatal sepsis? They're asking. It's jaundice. That is after 24 hours of birth. Jaundice is, is not a risk factor, except they're asking, so it is not a risk factor. Physiological jaundice presents after 24 hours of the birth. If it presents before 24 hours of birth, then it becomes a risk factors. These are all the risk factors what we are discussing, or you need to be aware of. These are clinical red flags also you need to be aware of regarding the neonatal sepsis. A limping child, they're asking the line drawn here, what does it denote or what is it known as? This is known as Killian's line. The sign is known as Tritowan sign. It is a diagnosis of slipped upper femoral epiphysis. So you need to be aware of what this line is known as, what this sign is, what is the diagnosis. Line is Killian's line, diagnosis Tritowan sign. The diagnosis is slipped upper femoral epiphysis. Same thing here, they're asking the diagnosis. They're given here is the given. If you draw a line going straightwards, it's not bisecting the femoral head. Same thing is happening on the side. So slipped upper femoral physis can be bilateral. This is a Tritowan sign, what we call it. It is seen in slipped upper femoral epiphysis. Amoxicillin covers which organism? Amoxicillin, ampicillin covers Listeria organism. It's usually recommended in patients who are older than, I think if I'm not wrong, 55 years old and younger infants or younger group of patients, because they're more prone for Listeria infections, especially when you're suspecting meningitis. That's why they recommend you to start on amoxicillin or ampicillin. Type of fracture they're asking here, or the Slatter's classification, which one they are asking. Only this much. Here is the fracture line what you're having. This is nothing but type 3 or type 3 type. This is the lower part, is the type 3 what we are talking about, where the vertical fracture passes through the epiphyseal joint through the epiphyseal plate. A 2-year-old kid brought to the emergency department with a history of fever and upper respiratory tract infection, lives with grandparents, and medicine for the fever was given recently, now comes with a right upper quadrant pain and altered sensorium. So something is wrong with the liver, something is wrong with the brain here, and lives with the grandparents and had a fever and respiratory tract infection. Keeping this in mind, this also suggests you have something is wrong with the liver. So this is a Ray's syndrome, where you see an encephalopathy and liver. This usually happens when you give aspirin for the fever. This is no longer seen because we are most commonly using paracetamol nowadays, not using aspirin. Aspirin, we are suspecting here to be given because older age group people still might be using aspirin, because few decades back, it was an aspirin which was used for febrile illness or to bring down the body temperature. So most likely these grandparents here might have given aspirin. That's why the symptoms this patient has presented with. So most likely diagnosis here is Ray's syndrome. 7-year-old kid presents with history of peritonitis, erythematous rash, and fever. A diagnosis of mumps was been suspected. When do you notify? You need to notify within 72 hours of suspecting, not diagnosing. Okay, suspecting. Whenever you suspect itself, you need to notify within 72 hours. You can go through this guidelines what you have put up here. Whenever they mention an urgent, you need to refer them within or notify within 24 hours. Whenever there is mentioned routine, like here in acute encephalitis, you can notify within 72 hours. This you need to be aware of. You can just remember the routine, which is easy to remember. There are few of the routine ones. Rest everything is urgent. You can remember in that pattern. Now we are having a 2-year-old kid brought to the emergency department with history of cough and cold since 3 days. Yesterday night, was having a noisy breathing. The kid is in sitting tripod position, still not interacting with anyone, slightly rosy, audible stridor, and saturations are 80% on room air. Oxygen is already started by the next best step they are asking. Low saturations, audible stridor, slightly drowsy. If you keep this, slightly drowsiness itself gets 5 points. Audible stridor itself gets 2. Oxygen saturation less than 92% gets 5 points. It's scoring very high. On what score I'm talking about? Westley's group score I'm talking about. It's scoring in this range between severe and impending respiratory arrest. At this point of time, the treatment of choice will remain to give an adrenaline nebulization so that you can, by that time, later on, you can give the steroids. So the right option on next best step here will be adrenal nebulization, what you need to give. A 9 months old child has been brought to the emergency department by parents, complaints of child going floppy and turning blue for 5 to 10 seconds, then recovers completely. Similar NC 10 days back. On examination, child is completely stable. Next best step they are asking. This is basically a diagnosis of Bruvi, lasting less than 1 minute, 9 months old, less than 1 year, a life-threatening event which has happened. It is in Bruvi, and child has got back to completely normal. It's in definition of Bruvi here. Whenever there is a Bruvi, you need to first see whether it is in low risk or this is an high risk. If it is in high risk, they require an admission to be done. Along with an admission, admit this patient. Along with an admission, minimum I'm talking about, you need to get ECG and capillary blood gas needs to be done. So out of this option, if you see ECG with capillary blood gas and admit for observation will come as a right option. So this is important for you guys to remember. Again, we have a 9 months old child brought to the ED by her parents, complaints of child going floppy and turning, same history, then recovered completely. On examination, child is completely stable. Which one of the following will warrant for investigation and observation? They're asking which one of the following is a high risk factor. This is an low risk, this is an low risk, this is also low risk, this is also an low risk. Remember, CPR given by trained practitioner, not by parents. Trained practitioner warrants you for admission and getting an ECG and capillary blood gas. This image is, or what you are seeing is a maculopapillary rash. Okay, now let's go through the history. Here, the 5 years old kid presented with an abdominal pain since last 2 to 3 days, associated with joint swelling and pain. On examination, you notice this rash, and what's the investigation which will help you with diagnosing? Abdominal pain, joint swelling with a maculopapillary rash. You need to suspect of HSP, that is henoch-scoline purpura. It's a clinical diagnosis, but there is one more feature which will be present, which is not there in the history, is hematuria. There might be microscopic hematuria. Getting an urine dipstick or an urine routine will help you with the diagnosis. But remember, it is a clinical diagnosis. What you need to do, this will just help you with the diagnosis. It's not an diagnostic test. Child has an alleged history of consumption of magnet 4 days back, and seen by a colleague, he advised come back if there are any red flags. They have come back because child has been having an abdominal pain and vomiting. If you see, it is there in the abdomen and the patient is symptomatic. When the patient is symptomatic, then you need to suspect or you need to operate on this patient. That is, you need to remove the magnet what is there here. It looks like well below the level of diaphragm, well below the stomach. So endoscopy can't go or reach here. So you need to do a laparotomy and remove it, because colonoscopy or endoscopy will not go to that level in the ileum, or it looks like in center of the abdomen and small bowel. If you're asking this one, there is a no Bruvi option itself. If you're asking here, there are again no Bruvi option itself. I don't know which option you're asking. Why not D for Bruvi? I don't understand. A 4 years old child brought to the emergency department. Mom has noticed child is limping since last 3 to 4 days. On examination, restriction of right hip joint and kid is febrile. So around 4 years old, febrile illness, out of these options given, it is only seen in transient synovitis. But remember that if they would have given one more option as septic arthritis would have been most likely diagnosis. Always septic arthritis should be at your top of your differential diagnosis. And if they have given that, you need to select that one. You always rule out septic arthritis. It is a true emergency. 2 years old kid, two, no, you need to admit no. It is a simple question which has come out as an explained to you and written also in the slide that you need to admit it no. Okay, you can't make this simple mistakes. It will become difficult in the exam if you miss it. And Bruvi, if within high risk factor is present, and if you don't admit, if you're discharged, then it will be very difficult for you in the exam. A 2 years old kid brought to the emergency department with complaints of noisy breathing and history of cold for 3 to 4 days. Stridor is present. At rest, they're talking 2 points comes here itself. Oxygen saturation is 92% on the room air. You're suspecting a croup. You're given an dexamethasone orally. Soon after giving dexamethasone, child has vomited. What you will do here? Child has usually choice of steroid is dexamethasone. Route is orally. You don't want to prick the child and make him uncomfortable. He has vomited, so you need to give steroids. Next best step is you give it in a nebulizer. If you give an oral way or oral method, if you give it, then it will become difficult. Why it becomes difficult? Again, they might vomit. IV, you need to prick, so you don't want to prick this kid unnecessarily. So budesonide nebulization will become the most obvious choice here. A 2 years old kid brought to the emergency department with complaints of severe episodic. The word episodic is important. Completely stable in between the episodes here. Mom has noticed there is an stool color which is reddish in color. This is nothing but they are talking about current jelly stool. Reddish color is in the stool is nothing but current jelly stool. They can describe as a current jelly. Current jelly stool with episodic. This is important, this word episodic abnormal pain. That means in between episodes is completely fine. Always suspect an intussusception. This is nothing but telescoping of one part of the bowel into the another part. Usually it happens at the ileocecal junction. Adrenaline is only given in life-threatening or a very severe kind of. So Wesley's group classification is very important. If you do an Wesley's group's classification, the scoring, that's why I did it here, will be less than 5. If less than 5, you are just giving steroids. Adrenaline is used only to buy the time. It is not helpful for recovering from an group. Okay, the inflammation should come down, so you are using steroids. Adrenaline will not help in that per se. A 10 years old sustained an injury to the elbow while playing football, complaints of severe pain in the elbow joint. They're given the elbow joint, they're asking likely diagnosis. This is dependent on the ossifying center. Whenever they give this view and ask you for a diagnosing, they want you to remember the ossifying centers. Remember the Critol mnemonic. Critol mnemonic is important. It's 1, 3, 5, 7, 9, 11. You need to remember this. This C stands for capitulum, R stands for radial head, I stands for internal epicondyle, T stands for trochlea, O stands for olecranon process, L stands for lateral epicondyle. Here you can see trochlea is present. This is nothing but trochlea. Trochlea is present. Ossifying center of trochlea is present. If ossifying present, before this what appears is internal epicondyle. Here there should have been an ossifying center which is missing. That means there is an medial epicondyle avulsion. This will be the commonest one. Just remember how to pick up or how to see and trochlea. If trochlea is present, there should be one more ossifying center here. If this is absent, that means there is a medial epicondyle avulsion. Most likely this has been displaced here. If you see here, this most likely has displaced here, medial epicondyle. A 5 years old child came to the emergency department with a rash over the trunk here. Okay, and has a history of sore throat 2 weeks ago. What is the investigation to support your diagnosis? Here they are asking. Sore throat 2 weeks back, they are talking about after 2 weeks, they have developed a rash. Most likely, this sore throat is caused by strep pyogenes, also known as group A beta hemolytic streptococci. So whenever there is a strep pyogenes infection, they can have an complications. One of the cutaneous complications they can have is having a rash. That is nothing but a sandpaper rash. Usually they'll have rough to feel sandpaper rash. They might be having a strawberry tongue also on further examination. Put this together, this is nothing but a scarlet fever this patient is having. So to know whether this is a streptococcal pyogeny or to support your diagnosis, you can get AS4 titers. most likely or more commonly you will be getting and swab, that is rapid test you will be doing. A 10 years old boy started having pain in the left hip after playing football 3 days back. X-ray of the pelvis is shown below. Vitals are stable. X-ray finding they are asking here. If you see here, you're drawing a line just below the greater trochanter here, and this line should bisect the femoral head. It is not bisecting the femoral head. That means Tritovan sign is present. If Tritovan sign is positive, is then diagnosis for slipped upper femoral epiphysis. A 4 years old guy brought to emergency department within 2 days history of fever. Which one of the following is an indicator of high risk in this patient? Grunting. Grunting is kind of favorite. They are asked twice in the examination as you have seen here. 9 months old kid brought to the emergency department with an barking cough. History of cough and cold since last 2 to 3 days. There is a noisy breathing on examination. There is a stridor, tracheal tuck. Everything is very classical of croup here. So diagnosis group, most likely organism causing the croup is parainfluenza. So right diagnosis here will be parainfluenza. Pain in the left or the right side, both here it is in bilateral bilateral slipped upper femoral epiphysis what this patient is having. Okay, so they can present with unilateral pain. Later on they can develop in bilateral pain. So the diagnosis here still what you're seeing is in Tritovan sign. Young child presents to the emergency department with history of coryza, presently having bilateral ankle swelling with maculopapillary rash. Likely diagnosis: ankle swelling with an maculopapillary rash. Think of HSP. Ask more history about abdominal pain and hematuria. Those are the 4 symptoms which usually presents in an HSP, that stands for Henoch-Scollin purpura. A 2 years old presents with an barking cough. You have diagnosed with an croup. According to Wesley's group classification, which one of the following carries an point, single point, 1 point they're asking? Saturation less than 92%. If it is at, on exertion, it is 4. At rest, it is 5. So it is not the. Sinus is on exertion is 4 and at rest, it is 5. Fever, it is not included in Wesley's group score at all, so it will be 0. Stridor at rest carries 2 points. Mild reduced air entry carries 1 point. So the right option or the right answer here is the 5. 31 weeks preterm baby brought to the emergency department by worried parents. Complaints of brief loss of consciousness followed by baby turning blue in color. Which one of the following is an high risk for Bruvi? They are asking. Out of this following, high risk for Bruvi is less than 32 weeks. There is a preterm. This is 31 weeks preterm. It is less than 32 weeks preterm is in high risk. Here it is an 31 weeks preterm, so that becomes an high risk. Rest of the following are not high risk. This is actually included in the definition of the Bruvi. Skin color change or respiratory efforts that's going no respiratory efforts at all. Apnea, it's included in it is included in the definition of Bruvi. Worried mom gets her kid to the emergency department as she was worried, as she has noticed blood in the diaper. History of intermittent inconsolable cry is present. Intermittent inconsolable cry, blood in the diapers, putting two together, it is interception. Okay, blood, whenever they say current jelly, you need to think about intermittent crying, because this is a small case. They might not say abdominal pain, they might just cry. This is a classical sunburst appearance. If you see in our first class, we had first or second class, we explained the sunburst appearance is classical finding of an osteosarcoma. Having sarcoma also, you need to be aware of, okay, onion peel appearance, what classically you will be seeing. Now going into surgery chapter, we are going into or entering into. We have a 34 years old male male patient to the emergency department with abdominal pain and multiple episodes of vomiting. X-ray is shown. X-ray is clearly suggestive of a small bowel obstruction, what you can see. Out of these options, which can cause a small bowel obstruction? Hernia. CA and volvulus usually causes large bowel obstruction. Elderly female presents to the emergency department with abdominal pain and bloating, no significant past medical history. On examination, diffuse abdominal tenderness. X-ray is shown below, most likely diagnosis. This is nothing but the dilatation bowel loops. You can see it is in the periphery. This is in large bowel obstruction. Which one of the following hernias will cause a large bowel obstruction? Only one kind of hernia can cause this, that is lumbar hernia. So you need to be aware of this hernia and what they are, what their specialties are. For example, femoral hernia more commonly seen in females, and it comes below the level of inguinal ligament. Then obturator hernia is very much similar, and periumbilical hernia around the umbilicus it appears. So you need to be aware of different hernias. They have asked multiple questions on hernias in previous diets. This is again a diagnosis of pyloric stenosis. So we have an hypochloremic metabolic acidosis, vomiting after feeds. Around 9 weeks they are presented. So it is classical history of pyloric stenosis. This finding, you remember, they can test you or they can give you the options. You make a diagnosis of pyloric stenosis, lab investigations can show which of the following findings. That kind of question can appear in the exam. Just pain radiating to the back, but it has come down with the painkillers. On examination, there is a diastolic murmur. ECG is normal, but D-dimer and troponin are elevated. What's the most likely diagnosis they are asking? This diastolic murmur might be suggestive of an aortic regurgitation, pain radiating to the back with high troponin and high D-dimers. Remember that troponin is not only elevated in MI, there are other causes also. For example, there are various other causes. For example, any tachyarrhythmias, it can be elevated. In aortic regurgitation, in aortic dissection, it can be elevated. Post angioplasty, it can be elevated. So there are various conditions where troponin can be elevated. One of the conditions is aortic dissection. So keeping in mind, just radiating to the back, especially interscapular radiation will be there. Presence of a diastolic murmur most likely suggestive of an aortic regurgitation. With high D-dimer and troponin, all goes in favor of aortic dissection. Don't get confused with pain reducing with pain coming down. It can happen in aortic dissection. Pain can reduce. When it is not breaking or it is not ripping the aorta apart, the pain can come down with the painkillers like morphine. Here, ECG, what you are seeing, the X-ray, what you are seeing is suggestive of a small bowel obstruction. So it is an easy diagnosis, small bowel obstruction here. But they're asking what's the probable cause. Probable cause here, if you see this one, cecal volvulus or segmental volvulus, ASIA, colon, all causes large bowel obstruction. Paralytic ileus is seen in hypokalemia, so the potassium levels are low. This is a functional cause for small bowel obstruction. This is paralytic ileus is the most likely cause here. So you need to be, or you should be aware how to differentiate between a small bowel obstruction and a large bowel obstruction. Especially look for valvulae. It passes through and through. This white line passes through and through. The white line, what you're seeing here, passes through and through. You need to be aware of that one. Here you should be aware of the Hostel line, which doesn't pass through and through. It just comes here and it's not going all the way. Here, what you're seeing. That is important, and it will be more central small bowel obstruction. Large bowel obstruction will be more peripheral. These findings you should be aware of. Which one of the following complications you can expect in a patient of aortic dissection? What happens in aortic dissection? If you consider this as an heart and this as an aorta, whenever there is an aortic dissection, it is dissecting, this wall gets broken down and blood starts moving backwards, and okay, it can go and accumulate in the pericardial space, resulting in pericardial effusion. Most of the patients who present to the emergency department die because of cardiac tamponade, die because of the complication of cardiac tamponade in the emergency department, rather because of aortic dissection itself. If it's an proper aortic dissection which is leaking, they will not present to the emergency department, they'll die at the scene itself. Here is a very elderly 70 years old chap who has presented with severe pain in the left lower limb. It is pale, cold, no peripheral pulse is present. You don't have a general surgeon, you only have a general surgeon available in your emergency department. What you will do next best step? Definite management in this patient. Refer to vascular surgeon. The first step also will be to refer to the vascular surgeon. You can't do much in the emergency department. Only vascular surgeon can revascularize it by doing an intervention like endovascular embolectomy he can do, or endovascular thrombolysis he can do. Those are the preferred techniques what they do it. So referring to the vascular surgeon is the first step in acute limb ischemia. and it's the definitive step also. Once you're done this, then you can give an bolus of 5,000 units of heparin. Investigations comes very later on. There's a Rutherford's classification you can go through. It gives beautifully when to investigate and when not to investigate. Elderly female on on ultrasound abdomen, you find an abdominal aorta diameter of 4.4 centimeters. Next step. So you have just found it. This patient is not symptomatic. If this patient is symptomatic, requires immediate intervention. If this patient is asymptomatic, what we see? We see the aorta diameter. If it's more than 3 centimeters, we can label them as triple A. Doesn't have an abdominal, you're doing some ultrasound scan and you have an incidental finding of an aorta being more than 3 centimeters, then you will just refer to the GP so that they get a closer follow-up. So just advise to follow up with the GP so that they can closely follow up this patient. If the same diameter is more than 5.5 centimeters as an incidental finding itself, then you might have to refer directly to a vascular surgeon, because intervention will be required whenever it is equal to or more than 5.5 centimeter, the AAA, that is abdominal aorta aneurysm. A 70-year-old patient come to the emergency department complaining of abdominal pain, constipation, vomiting. On his visit to the GP, the doctor has told him that GFR, that is, he is in chronic kidney disease or there is some injury to the kidney. On examination, patient is having guarding and rigidity. Best initial step. Guarding and rigidity, always suspect there is peritonitis. Abdominal pain, constipation, and vomiting with guarding and rigidity, most likely this patient is having a perforation, bowel perforation has happened. So always get an erect abdominal X-ray covering the diaphragm. Why? Just below the diaphragm, you will be seeing if there is any air under the diaphragm. That finding you want to find out. So getting this investigation done is the most important. You getting a CT scan without contrast will not be helpful. CT scan with contrast, try to avoid it, because this patient has a kidney failure. It will damage, he might go into dialysis. Diameter AAA from outer to outer or from inner to inner. It should be from outer to outer what you need to measure. Elderly patient on hemodialysis presents with right upper limb AV fistula in situ. Nurse notices absence of palpable thrill. What will be next? You don't know why there is absence of thrill. So get an upper limb Doppler. Depending on the findings, you might have to involve the vascular surgeon. Likely diagnosis on the X-ray they are asking. On the X-ray, if you see, this is a classical presentation or classical X-ray of sigmoid volvulus. You can see here, you need to should be able to differentiate between sigmoid volvulus and cecal volvulus. Sigmoid volvulus, it appears like a coffee bean what you see, or inverted U shape what you see, usually displaced in the right upper quadrant. Right upper quadrant is the usual, but sometimes it might be in the left upper quadrant or anywhere in the abdomen. Here what you can see in the cecal volvulus, usually it looks like a dilated loop, one single dilated loop. It doesn't look like a coffee bean appearance. That will help you to differentiate between sigmoid volvulus and cecal volvulus. Forceful vomiting with chest pain, difficulty in swallowing, X-ray is given. What's the X-ray findings we are having here? The X-ray you can see here, this subcutaneous emphysema. That means air is in the subcutaneous tissue. Subcutaneous emphysema with chest pain and violent vomiting. Most likely violent vomiting has resulted in ruptured esophagus. Ruptured esophagus has resulted in leak of air from the from the esophagus and resulting in subcutaneous emphysema here. That's why this is known as Boerhaave syndrome. Forceful vomiting resulting in a ruptured forceful vomiting might result in a ruptured esophagus known as Boerhaave syndrome. Forceful vomiting only damaging the mucosal membrane resulting in bloody vomitus is known as Melleris Weiss. In that you will not see subcutaneous emphysema because there is no rupture of the esophagus. GFR usually should be more than 120. Anything less than 120 we call it is like basically checking and creatinine. It usually shows the renal function. 30 is usually a severe renal dysfunction you are suspecting. Elderly patient with diffuse severe pain abdomen, examination is completely normal, no improvement with painkillers. Lactates are very high. What is the diagnosis? It's a mesenteric infarction or mesenteric ischemia. Don't get confused with ischemic colitis. Ischemic colitis is different. Ischemic colitis is seen in watershed areas, usually seen at the junction. Usually, the patient will have pain in the left upper quadrant, and it is seen at the at that region because the blood supply. If you take this as a large bowel, the blood supply at this region is very much hampered. This is an intersection between an superior mesenteric artery and an inferior mesenteric artery. That's why it is known as watershed area, and usually ischemia at this region is known as ischemic colitis. Mesenteric infarction usually happens because of the embolus, and usually embolus will be in superior mesenteric artery because the angle is very obtuse. If you see the superior mesenteric artery from the aorta, it comes in an obtuse angle. So most commonly involved artery is a superior mesenteric artery. Elderly male presented to ED with severe abdominal pain. On examination, there is a diffuse tenderness of the abdomen and rigidity. Lactates are high. Though examination you are having findings, lactates are quite high. Whenever the lactate is quite high and there is severe abdominal pain, again think of mesenteric ischemia. Mesenteric is severe abdominal pain with lactate high, mesenteric ischemia until and unless proven otherwise. The diagnostic test here will be to get an CT angiogram done. That is CT with IV contrast. Which one of the following will cause a painless rectal bleed? Out of this following, only hemorrhoids causes painless rectal bleed. Hemorrhoids are two kinds. One is internal hemorrhoids, one is external hemorrhoids. You need to be aware of. Internal hemorrhoids usually causes less pain, or mostly they will be painless. They'll be less painful, and it will be present with bleeding. So it will be more likely it will be painless and bleeding. External hemorrhoids usually are more painful and no bleeding will be there. CT contrast or CT angiogram. There is very minute difference between CT contrast and CT angiogram. Both you give IV contrast. When you give an IV contrast, you can visualize the arteries and veins beautifully. When you're taking in slightly different sequence, you call it as a CT angiogram. CT angiogram, if you ask me, the preferred one will be CT angiogram. But in CT contrast also, you can make a good enough diagnosis. CT angiogram will be the best if you compare with the CT contrast. Elderly patient presents with left loin pain radiating to the groin region associated with hematuria. Patient also complains of dizziness. Elderly, any patient who comes with this thing, which is suggestive of an, most likely if it's an young patient, we think of an ureteric calculi. Here you need to think of an triple A. He's thinking of an triple A, that's why he got an abdominal scan done. Ultrasound scanning for triple A he has done. On that, they have found it to be 3.5, sorry, this is not millimeters, please correct in your notes also, it is centimeters. And no fluid is seen. Next step they are asking, because it is 3.5 centimeters, that is more than 3 centimeters what is having, and this patient is having symptomatic, might require intervention. So urgently contact surgical reference for making a decision. Here will be the most appropriate decision. You can't shift this patient out to get a CT scan done. Triple A is not ruled out. It is actually in triple A here what is happening. Reconsider diagnosis. No, it is in triple A what is happening. So you can rule out also and come to this conclusion. Patient presents to the ED with severe right lower limb pain since last 6 hours. On examination, there is an absent dorsalis pedis pulse, pallor, and decreased toe movements. Next best step. Next best step or definitive step is urgent referral to the vascular surgeon. Giving any anticoagulants like rivaroxaban or doing any investigations are not preferred. Whenever you're doing a clinical diagnosis sufficient for acute limb ischemia, you're diagnosed clinically, it is very much suggestive of an acute limb ischemia. Directly, you need to involve the vascular surgeon here. Elderly male presents with vomiting and constipation. X-ray of the abdomen is shown below. Likely diagnosis they are asking you. If you see, this isn't small bowel obstruction. This can cause small bowel obstruction. This can cause small bowel obstruction. Adhesion also can cause small bowel obstruction. Which is the most commonest cause for small bowel obstruction? Adhesion. So select adhesions here. A 35 years old farmer, fully vaccinated, suddenly sustained a lower limb injury while farming. Not known to have any comorbidities, delivers swelling as shown in the picture. While waiting in the triage area, deteriorates and becomes toxic and febrile. Sudden deterioration, what you're saying. Whenever there is a sudden deterioration after an injury, especially in farming setup, think of necrotizing fasciitis. With the image and the history, sudden deterioration, you need to think about necrotizing fasciitis. So the right answer here will be urgent surgical reference for debridement will be the right option. Elderly patient known case of dementia presents to the emergency department with nausea, denies any oral intake. On examination, patient's abdomen is distended, tympanic node on percussion, likely diagnosis they are asking. Okay, distended abdomen, tympanic node. Tympanic node, where and all you see. Okay, out of this given option, diverticulitis can have tympanic node, volvulus can have tympanic node, but bowel distension and nausea and denies oral intake, this goes in favor of volvulus, large bowel obstruction. So the right answer here is volvulus. It has appeared twice in the examination. It is a necrotizing fasciitis. What you are seeing doesn't look like an gangrene what you are having. Okay. Again, if you're thinking of gangrene also, it requires an urgent debridement. Both, they're not asking the diagnosis there, they're mainly asking for the treatment per se. A 23 years old male came to the ED department with history of dandruff, fever, and abdominal pain. What is the test for confirming the diagnosis they're asking? Glandular fever, they're asking, confirming the diagnosis they're asking here, not the confirming the complication. If they would have asked the complication, then ultrasound would have been the right answer. They're asking the diagnosis, so monospos test you need to get. The diagnosis, or what we are thinking here, is infectious mononucleosis, also known as EBV, caused by EBV virus. Infectious mononucleosis is the diagnosis what we're thinking, also known as Kissing's disease. Okay, there is nice guideline for this, how to go about the investigations. First test usually will be an heterophile antibody test, also known as monospos test. Fasciotomy, when do you do an fasciotomy? You do an fasciotomy for what? And compartment syndrome. Does this patient has a compartment syndrome? No. So fasciotomy will not be helpful. You're going to do an incision and drainage here. Child with seizures for 30 seconds, seizures stopped, but once you receive the child in post-ictal state, examine, you notice that the image what is shown below, likely nerve involved. Seizures, post-seizures, most probably there is increased intracranial pressure that has lead to an uncal herniation. Uncal herniation will cause compression over the middle brain. Middle brain, you see the third cranial nerve. So most likely there is an involvement of third cranial nerve. Third cranial nerve will present with an unequal pupil. One is dilated, one is non-dilated. So dilated pupil side, what you need to look out for, most likely, and left oculomotor nerve, also known as third cranial nerve, is involved. Surrounding it it will be an parasympathetic nerves. Involvement of that causes a dilatation of pupil. Involvement of that will have an unopposed sympathetic action resulting in a dilated pupil. 19 years old patient came to the ED with epistaxis. Cautery is done. What's the most common complication? Because of the cautery perforation. Remember that if you have an bilateral nasal bleed, so the left and right side nasal bleed you are having, don't cauterize on the both sides. If you cauterize on the both sides, chances of perforation will be very high. You shouldn't do bilateral cauterization. Most common complication of cauterization is perforation. Remember that. A 49 years old male came to the emergency department with complaints of headache, vomiting, severe sudden painful vision. What is the most probable diagnosis they are asking? Painful vision loss. You should always think of glaucoma. All three will cause painless vision loss. Systemic symptoms like headache, vomiting are more commonly seen in acute angle closure glaucoma. They also present with mid-dilated pupil, which is not reactive to the light, and circumcorneal erythema. 40 years old female presents with spinning sensation and with movements of the head since 8 to 10 hours. History of multiple episodes of vomiting are present. On examination, which one of the following indicates a central cause or vertigo? Out of this, for example, tinnitus is a Meniere's disease. Head impulse test is a vestibular neuritis. Unilateral horizontal nystagmus can be seen in BPPV. It is a peripheral cause for vertigo. Bidirectional vertical nystagmus. Bidirectional or vertical nystagmus, both are more suggestive of a central cause. So B is the right answer here. What we're seeing in this picture here, we're seeing an irregular pupil. The pupil is not round, irregular pupil. This is seen in anterior uveitis, also known as iritis. Along with it, you can see here yellowish color. This is nothing but pus which is accumulated in the anterior chamber. This is because of a lot of inflammation. Pus can accumulate in the anterior chamber. It is also seen in anterior uveitis, also known as iritis. It is known as hypophone. Sorry. Which one of the following symptoms are associated? They are associated with pain during accommodation. This is the classical symptom. Pain happens during accommodation in anterior uveitis, because people will not be able to move because there are adhesions between the iris and that of the lens. Because of these adhesions, people will not be able to constrict properly or dilate properly. That's the reason, the same reason for irregular pupil also. This image with tongue protrusion and swelling of the neck itself is suggestive of an Ludwig's angina. Okay. With the history of difficulty in swallowing, neck pain, and history of tooth extraction. Tooth extraction history will always be present in Ludwig's angina. Presence of this is suggestive of an Ludwig's angina, or it is very much diagnostic of an Ludwig's angina. A 10 years old kid was brought by his father as he noticed fresh blood on the pillow, and the child has an tonsillectomy done quite long time back, 7 days back. On examination, there is no bleeding, but there is an increased heart rate, yellowish color discharges there, and some oozing from the operation site is present. So yellow color discharge and which is oozing from the operation site, think of most likely this patient is having bleeding because of the infection. Especially when they present after 24 hours of the tonsillectomy, you need to suspect an infection. So it's better to get CBC, RFT, cross-matching also, and give him IV antibiotics, because there is tachycardia is present. There is continuous discharges which is happening. So there might be an abscess which requires some drainage, and we don't know how much blood loss is there. So we need to get a cross-matching in to be on the safer side, and give him IV antibiotics. It's always recommended to give IV antibiotics if the bleeding is because of an infection. A 60 years old lady brought to the emergency department with vertigo and unsteadiness from yesterday. It increases when moving and continues even at rest. When she has nausea but no vomiting, on head impulse test is positive, screw test is negative, there's an unidirectional nystagmus on the lateral eye, otherwise normal. What is the next best step they're asking? Keeping all this in mind, the diagnosis is a peripheral vertigo. Peripheral vertigo is, here to be more precise, is vestibular neuritis, because head impulse test is positive. It is very specific for head vestibular neuritis. What we do for vestibular neuritis, it's basically a viral inflammation. You just leave it as such, it will recover. But this patient is symptomatic, so give him something for the symptoms like prochlorperazine, which can be given intramuscular, or it is available in the tablet form, or you can give antihistamines like beta-histine and discharge them home. Tell them it will take few days to resolve the symptoms. You will be fine. Admission will not be required. So these are the differential diagnosis for peripheral vertigo. What are the presentations we have given? How to differentiate between them? I have given here. Go through them. This is important. A 34 years old male complains of sore throat. Image is shown below. He is a known case of IV drug abuse. Investigation of choice. This is nothing but inflamed tonsils with some pus discharges there. So it can be anything. Mainly it is a sore throat along with tonsillitis this patient has presented with. But this patient we are suspecting to be immunocompromised because he is an IV drug abuser. In immunocompromised individuals, it is recommended to get an throat swab done to see whether it's a streptococcal infection. If it is a streptococcal infection, you need to prescribe them the antibiotics because he might be immunocompromised. That's the reason we do a strep test, a throat swab rapid strep test. We do it in the emergency department. It might be an EBV, that is an infectious mononucleosis. Paul Bennell test might be required. But again, what is the treatment for infectious mononucleosis? It remains symptomatic. We don't prescribe them anything, or there's no specific treatment for infectious mononucleosis. So no need to investigate for infectious mononucleosis in this scenario. This image, what you're seeing, is suggestive of an chemosis. This conjunctiva, what you're seeing, this is nothing but chemosis, what this is having. it is commonly seen in conjunctivitis. Okay, conjunctivitis, with this image, what you're seeing, what we need to do, we need to bring down the symptoms what this patient is having. So antihistamine drops will be the right option here. Steroids can also be prescribed, but the recommendation is steroids needs to be given only on the ophthalmologist advice. So you on your own shouldn't prescribe steroids in this condition. So diagnosis here is conjunctivitis. This is a severe form of conjunctivitis. The image what is shown is chemosis. Treatment what you'll be giving here is antihistamine eye drops should be sufficient. Which one of the following is not a feature of anti-uveitis? Part of the anterior uveitis, which is also known as iritis, is ciliary body. Okay, it is a part of the anterior uveitis. Ciliary body is responsible for the secretion of aqueous humor. If ciliary body is involved, secretion of aqueous humor will be reduced. If secretion of aqueous humor is reduced, there will be reduction in intraocular pressure. So the right diagnosis here will, which one of the following is not seen? They're asking, not seen is raised intraocular pressure. A 45 years old male came to the emergency department with complaints of blurring and pain in the right eye. Symptoms are associated with floaters and headache. He has a significant past history of lower back pain for which he takes medications. So if you put everything together, it becomes a diagnosis of anterior uveitis. Blurring of the vision, pain in the right eye associated with floaters and headache. This lower back pain, why they have given, they want you to think about ankylosing spondylitis. Okay, why I'm thinking of ankylosing spondylitis? I'm thinking of ankylosing spondylitis because anterior uveitis is an HLA-B27 disorder. This is a group of disorders what you see. Ankylosing spondylitis, anterior uveitis, all belongs to HLA-B27. So back pain with this eye symptoms and the floaters, what you're seeing, these floaters are because of the inflammatory cells in the anterior chamber. They see the floaters. All goes in favor of anterior uveitis. On this image, which nerve is involved, they are asking. This eye looks considerably normal. This eye, if you're seeing, the eye is deviated downwards and outwards, and there is some amount of ptosis is there. Downwards and outwards resting position of the eye, along with the ptosis, think of oculomotor nerve involvement. Again, it's in sore throat, you're prescribing antibiotics, patient is immunologically stable. Because he might be immunocompromised, we don't want to risk it. This patient is not in sepsis, or they're not dealing with in sepsis there to get a blood culture done. If you're thinking of in sepsis, and if you're planning to get blood cultures done, then you need to admit him and give him IV antibiotics. IV antibiotics at that stage is not recommended. Usually even antibiotics are not recommended. We go according to fever pain score, and those are the nice guidelines. They recommend not to prescribe antibiotics according to fever pain score. But if at all, if you want to prescribe an antibiotics, fever pain score should be high, then you prescribe antibiotics. Here the patient is immunocompromised. We want to just confirm it's not a strep infection because they're prone for the complications. What are the complications? They can have post-streptococcal glomerulonephritis, or they can have scarlet fever. Scarlet fever more for the pediatric age group. Post-glomerulonephritis is a well-known complication, can occur here. To avoid that, we need to give antibiotics. For that reason, we are getting the test done, rapid step test from the emergency department. Most appropriate, we are asking here. Coming back to this question, a 36 years old female, unknown case of Sjogren's syndrome, presents with pain and swelling around the submandibular region, worse on eating. Swelling around the submandibular region, worse on eating, Sjogren's syndrome. Sjogren's syndrome decreases the secretion, especially the salivations. Okay, the mouth will be very dry. Okay, in these conditions within submandibular, when secretions are very dry, calculi formation in the submandibular gland, salivary gland will be high. So it is nothing but an scaleolithiasis. This is nothing but is a condition in which stone forms in the salivary gland or the duct, and it blocks the flow of the salivation. So whenever they are eating, mouth should have some amount of saliva to digest it or grind the food what is there in the mouth. Just the reason it is the reason they will be having pain when they eat the food, or increase in pain or worsening of the pain when they eat the food. We have a 50 years old male came to the emergency department with complaints of swelling of the base of the mouth, and he had undergone third molar tooth extraction a few days ago. His vital parameters are stable. What is the next best step in the management? They're asking. If the vital parameters are stable, we need to get NCT neck done to see the extension of the abscess. This is nothing but a Ludwig's angina we are talking about. We need to see till what extent the abscess is. Ludwig's angina is nothing but floor of the mouth abscess it is. Okay, floor of the mouth, there is severe infection resulting in the abscess formation. So you'll be getting NCT neck done to see the extension and giving IV antibiotics after collecting the cultures. In the same patients, if they say the vital parameters are unstable, or if they say there is some drooling of the saliva, then you are suspecting there might be an airway compromise because of Ludwig's angina. At that point of time, ENT for tracheostomy or involving, involving the anesthetic will be the right option, because you need to secure the airway first. At that point, involving the anesthetic will be the right option. We are not sure whether the drooling of saliva was present in the stem of the question or not. So look out for, if there is drooling present, involve the anesthetic will be the right option. You will follow the difficult airway algorithm. Tracheostomy comes later on. So you will not directly jump into tracheostomy. You will first try to intubate the patient involving the anesthetic and having a difficult airway trolley along with you. They're asking what's the likely diagnosis here. If you see this X-ray, this here, what is there is a thumbprint sign. Thumbprint sign is classically seen in epiglottitis. No other things are required. Though other things like no previous vaccination history, drooling of the saliva, all goes in favor of epiglottitis. Remember that because of vaccines against H influenza virus, it has become rarer and rarer in pediatric age group to have an epiglottitis. It is becoming more and more you're seeing in the teenage group nowadays. High temperature, painful eye movement. So any eye symptom with and redness around the eye or over the eye itself, think of orbital cellulitis. Painful eye movements or restricted eye movements, and proptosis, all those features are all suggestive of an orbital cellulitis. Orbital cellulitis should be treated like in sepsis. You need to collect you need to collect cultures and start them on IV antibiotics, admit them. Anyone with orbital cellulitis, their chances of abscess formation and loss of vision. This is the reason you need to treat them aggressively. They're asking what's the most probable diagnosis. You can see behind the tonsil, there is a swelling. That swelling is nothing but peritonsillar abscess this patient is having. So the right diagnosis here is a peritonsillar abscess. Father has brought a child to the emergency department worried about he might have ingested a magnet. Next best step, just get a chest X-ray and abdominal X-ray to see whether he has ingested, because magnet is sensitive to, it can be picked up and it can be seen very well on an X-ray. So just get an X-ray done of both chest and an abdomen will be required, because it might be in the bowel loops or it might be in the esophagus. We don't know. That's why get both the views. A child is playing and has sustained injury to the nose. Image of the following is given, likely diagnosis. Here, what you are seeing is known as septal hematoma. This is the septal hematoma, what you are seeing, septal hematoma. Why is it important to examine the nose whenever there is inside? If it is a septal hematoma, it can cause suppression, pre-osteal stripping can happen of the cartilage, resulting in avascular necrosis of the septum. So you need to drain this septal hematoma. It is an emergency. So anyone who sustains a nose injury needs to be examined the nasal cavities to see whether there is an hematoma. Nasal fractures, we are not worried. We can ask them to follow up with the ENT after 2 weeks. If there is a nasal bone fracture, then they will get an X-ray done, and then if required, a manipulation will be done. It's more often cosmetic basis. You will not do any manipulation. You will not refer them early on, because if there isn't swelling, it will be difficult to diagnose, and no imaging should be done from the emergency department for the nasal bone fracture. Young female presents with fever, sore throat, upper abdominal pain. Here, with the image, you'll not be able to differentiate between a bacterial infection or an infectious mononucleosis, that is an EBV virus infection. But upper abdominal pain, in an EBV virus, there is an complication of an splenomegaly. Splenomegaly will result in upper abdominal pain, and sometimes this splenomegaly can rupture with trivial contact also. That's why you need to think of infectious mononucleosis. Most common organism which causing this is an EBV virus. Yes, a strong magnet or in regular magnet management will remain the same. If they're taken two magnets, immediately they need to be removed. If they're taken one magnet, if it's in esophagus, you have an option to wait for 24 hours or remove it immediately. If it's in a small bowel and he has taken one magnet, you can wait for him to pass. Okay, pass in the stools, what I'm talking about. If there are two magnets, depending on the position, you need to intervene. If it's in the esophagus, you will be doing endoscopy. If it's in the small bowel, you will be doing and laparotomy and remove it. Small bowel, large bowel, you'll be doing laparotomy and remove it. Patient is a known case of glaucoma. Which of the following drugs needs to be avoided? Both this tricyclic antidepressants and SSRIs needs to be avoided. Students have told us that both were given. Okay, we are not sure if both were given. This question will be deleted because there are two right answers here. What you're seeing here is an iris prolapse. You can see this is not round. Pupil is not round. Here there is some damage of the pupil. This is known as iris prolapse. Iris prolapse is seen in penetrating injuries. So most likely this is an impacted or an penetrating foreign body injury what this patient is having. Okay. Remember that it has appeared twice, kind of similar image. It has appeared twice in the examination. Slit lamp examination with the contrast or with the dye, what they're seeing, dendritic lesions are seen. This is nothing but an corneal ulcer because of herpes simplex virus, because of the dendritic lesions, what you're seeing. Eye drops are preferred. Preferred one is ganciclovir eye drops. You can treat them with an acyclovir ophthalmic drops, also trifluridine ophthalmic drop or ganciclovir ophthalmic drop also. Okay, oral acyclovirs are not preferred. It's a local application is preferred. They act very well for the local eye drops. Patient complains of left-sided hearing loss. Which one of the following indicates sensory neural hearing loss? They are asking. They are basically testing you on Rennes test and they are testing you on Weber's test. In sensory neural deafness, air conduction will be better than the bone conduction. And Weber, when you do an Weber's test, will strike and keep it on the vertex, and it will usually in the normal individual, it will remain on the middle itself. It will not be lateralizing to any ear. Lateralizing means it will not be heard better in any ear. Here in Weber's test in sensory neural deafness, it will be heard better in the normal ear. So it will be lateralizing to the normal ear. So if you go through the options here, B is more suggestive. That is, air conduction is better than the bone conduction on the left side, which is the affected side, is suggestive of sensory neural deafness. Go through conduction deafness also. They like to ask about Rennes test and Weber's test in the examination. So it can appear in the examination. Go through it. It is important from exam point of view. A 35 years old male came to the emergency department with a rapid swallowing. You're planning to insert, basically there is an blunt trauma is there. You're planning to insert an ICD for hemothorax. They're asking about the posterior border of the safety triangle. Anterior border is formed by pectoris major. The posterior border is formed by latissimus dorsi. So the right option here is latissimus dorsi. The base is formed by sixth rib. We call it as a safe triangle. This is called as a safe triangle because there are no major vessels or there are no major nerves here. So it is safe to insert an ICD here. Chest tube is inserted, insertion was done and done for pneumothorax with a Saldingham technique. Patient deteriorates suddenly after insertion, likely cause. Suddenly it has happened. It must be an artery injury which has caused the bleeding and it has deteriorated. Empyema is a late complication. That is basically an infection because of the ICD what you're inserted can cause infection inside the lungs, causing pus accumulation. It's a late complication. Retained pneumothorax will not cause a deterioration. It should remain the same thing. Nerve injury will not cause a deterioration. He will lose the sensation of that part of the supply of the nerve. They're asking which one of the following methods in which you will not use traction. Okay, basically there is a shoulder dislocation, anterior shoulder dislocation. Which one of the following doesn't use an traction? This all three methods use an traction. Coach's method doesn't use an traction to reduce the shoulder joint. Which one of the following is the best to find out the cannula needle is in vein or artery? You seeing and through an ultrasound image, you seeing it going into and the vein is the best way to do it. Okay, ultrasound non-compressible arteries are non-compressible because of their muscular curvature. Veins are compressible and arteries are pulsatile. all these features are more consistent with an artery, so ultrasound becomes a preference. ABG, if the patient is very sick, VBG and ABG may not be very different from waveform, also may not be very different from color. Also, if the patient is very sick, might appear both, and it is very vague thing to compare with. Here they are asking regarding the fascia iliaca block, which of the following is correct? In the fascia iliaca block, you will be using large amount, around 30 to 40 ml you will be using, not 4 ml you will be using bupivacaine. It can predispose to opioid overdose. No, wrong again. Less incident complication compared to femoral nerve block. Yes, that is true, because femoral nerve block is given very close to the femoral artery. Fascia iliaca block, at least you are a couple of centimeters away, if not 1 or 2 inches away from that of the femoral artery. So less complications during the procedure. Oral anticoagulants is a contraindication for fascia iliaca block. No, it's not a contraindication. It's not a contraindication. You can still go ultrasound guided. Femoral nerve block gives better pain control compared to fascia iliaca block. No, fascia iliaca block blocks 3 nerves. It blocks femoral nerve, it blocks lateral cutaneous nerves, and it might partially block. Some literature says it doesn't block, some literature says it partially blocks obturator nerve. Okay, so be careful with the obturator nerve, but it definitely blocks femoral nerve, and it definitely blocks lateral cutaneous nerve, and it pierces in fascia iliaca block. It pierces fascia lata and fascia iliaca. Those questions can appear. That's why I'm stressing that. During pericardiocentesis, which is the commonly injured structure they are asking, we don't have a source, but if you logically think, if we are going from ancivisternum, the angle, the first structure you encounter is the right ventricle. It's a large structure, so injuring right ventricle will be more common. That's what logically we are thinking. Ascending arteries or the phrenic nerve, they're smaller structures, might be missed, may not be so injured. This is more superiorly associated. Inferiorly is right ventricle. We go through an inferior approach, so right ventricle most commonly involved. What we are thinking, these are the complications what you can expect in an pericardiocentesis whenever you do as a complication of the procedure. After insertion of a central line, IJV patient complains of pain in the upper limb and it turns pale in color. IJV is located in the neck. Compartment syndrome in the neck can cause arterial compression, but it will not cause ischemia, because this arterial compression is happening in the neck. It causes compression of the carotid artery, so unlikely. Arterial cannulation. Please mute everyone. Vein thrombus is in late complications. Arrhythmia, immediately it happens, but it doesn't just causes ischemia of the upper limb. Most likely it is an air emboli which is causing, or which has gone through the vein and it has come to the upper limb and resulted in the ischemia. Okay, turn pale in color is more suggestive of an acute limb ischemia. We are thinking of an embolus, air embolus. Here you are inserting a central line. You see this on the monitor while inserting a central line. Pull back whenever you touch the cardiac muscle, because when you're doing an IJV excess, it might go into the right atrium. Whenever it touches the cardiac muscle, it triggers arrhythmia like VT, what you're seeing here. So pull the catheter back and monitor, continue monitor. Once you pull a catheter a little back a few centimeters, the arrhythmia disappears, nothing needs to be done. Ultrasound guided central line has been done on the IJV. How to check the correct position of the central line? Get a chest X-ray. What we are talking about here is the central line, how far it has gone. It should be just above, the tip should be lying in the superior vena cava. It should be just above the junction of right atrium and the vessel wall, and it should be parallel to the vessel wall. To see those things, X-ray is the best. That position they are asking about here. Tube is inserted and junior doctor wants you to confirm here. If you see here, this NG tube has gone in the central line till the level of diaphragm. Then it's gone below the level of left hemidiaphragm. So it is lying below the left side of hemidiaphragm. That means it is in stomach. So it is in the right position. You can continue with feet. Nothing else needs to be done. Continue with the face. It is in the right position. A 70-year-old male with distal femur pulse came to the ED department. Sorry, distal femur fracture came to the ED department and agitated and aggressive. Which one of the following is a drug of choice? He hasn't. Mostly he's aggressive because of the pain. He has gone into delirium and has become aggressive. Okay, what we'll do to encounter both the delirium and the pain what is having, ketamine becomes the drug of choice here. Femoral nerve block with an aggressive patient is difficult to give. Haloperidol is usually not recommended in an elderly patient. Lorazepam is the recommended choice, but benzodiazepines don't have any pain, any analgesic effect at all. So never give benzodiazepine for an analgesia because they don't have any analgesic effect at all. A middle-aged person has come in with an ankle dissociation. Research is very busy and no beds are available. You have only one trained nurse to help you out. You want to reduce ankle joint. Which one of the following drugs you'll use to reduce the ankle joint? You can't give an constant sedation here because there are no research beds. There's no other doctor available. Only one nurse is available. Then you can give a Penthrox and reduce it. This is a new drug. This is a generic name. It's a brand name Penthrox. Generic name is methoxyfluorine. It's a general anesthetic, doesn't require an ICU, doesn't require an research setup, or doesn't require any monitoring, and doesn't require two doctors. It has advantages of those things. That's why you can use Penthrox and reduce the ankle joint in that case. Which one of the following methods can be used to reduce the posterior dislocation of the shoulder? Remember that posterior dislocation, 95% of the time, it will not be possible to relocate. It requires internal reduction to be done. But you can try once. The method, what it is traction and external rotation. You need to give traction. One fellow should be giving traction. One fellow should be rotating externally, external rotation. So anti-clockwise rotation is required at 90 degrees to the body. So it should be abducted at 90 degrees. One fellow is pulling that arm and another fellow is rotating externally. This X-ray is very much suggestive of an ankle dislocation. How do you reduce it? Ankle reduction is a painful procedure, so you need procedural sedation. So this will be the right option here. You need not get an X-ray done. This is an emergency. If you leave it as such, there will be vascular compromise and skin tenting. Skin can break and result in an open fracture. So to prevent those complications, X-ray is not recommended. This is an obvious deformity is there. So you can go ahead with reduction directly. Here you can see this is the Ryle's tube or NG tube, nasogastric tube. It is not going in a straight line. It should go in a straight line till the level of diaphragm. It is not going in the straight line. It has deviated. So remove it immediately. It might have gone into the trachea, or it might have misplaced or punctured the esophagus. So remove it immediately. They're asking IO insertion site. Out of this, the correct IO insertion site is proximal humerus. Proximal tibia 2 meters above the patella? No. 2 centimeters below and medially, what you need to do? Distal femur 2 centimeters below lateral condyle? No. Again, it should be above. 1 centimeter below the medial malleolus? Again, it should be above. Okay. Another thing I need to stress is the preferred site both in adult and child is proximal tibia. Okay, proximal tibia is the preferred site in both in adult and child. If proximal tibia you are not able to insert, the second preferred site in child in the pediatric age group is distal femur. Okay, compare again in adult, it changes. In adult, it is proximal humerus which is preferred as a second one. So remember this, they can test you in the examination. The second, usually they like to proximal tibia, they'll say, or they'll not give you the option only. The second best choice, if it is a child, choose distal femur. If it's an adult, choose proximal humerus. Now we are going into SLO7, the last chapter we are going into. You are you are leading and trauma case, multiple casualties of the road traffic. You have a patient who has a blunt trauma, cardiac output lost since 45 minutes. Surgical physician wants you to do endoscopy thoracotomy, which you are against it. Your consultant busy in intubating a child from the same incident. He is not to be disturbed. What will you do? Override the surgical registrar because patient care is important. These are the indication for thoracotomy. So you're not inserting less than 15 minutes of CPR, less than here already 45 minutes. You know, clinically it is not required to be done here. So override the surgical registrar and do what is good for the patient. 80 years old female brought to the emergency department with symptoms suggestive of an urinary retention. Son is a caretaker. On examination, you notice multiple contusions over the lower abdomen and thigh. So you're suspecting it might be an adult abuse. Okay, child abuse is there, adult abuse is also there. So what you will do, whenever you are suspecting an adult abuse, the first step is you need to talk to the adult and ask whether she requires in safeguarding or not. Okay, if she says she requires in safeguarding, involve the social services. So discharge with social services to home. Send the social services along with the patient to home, so that they can see what are the social circumstances, what needs to be done, they will do, and they will take care of all those parameters. A 6-month-old baby was brought to the emergency department by his mother. Complaints of continuous crying. The baby was with the mother's boyfriend since the morning, and when the mother came back from homework, the baby was crying continuously. On examination, you find multiple bruises on the baby's body. You suspect and child abuse. What's the most common site for fracture? They're asking. Most common site for fracture out of given options in long bone fractures is the femur. But most specific fracture is a metaphyseal fracture. What you need to think about. Metaphyseal fracture is the most specific fracture which is more sensitive and specific for a non-accidental injury, usually seen in twisting injuries. Someone holds the leg and has twisted. Some carer has twisted the child's leg, results in a metaphyseal fracture. Most commonly, metaphyseal fracture happens of the tibia or the femur, and most common long bone fracture which is involved is the femur. A 4-month-old baby was brought to the emergency department, continuously crying. On skeletal survey, shaft of the humerus was found fractured. You are suspecting a non-accidental injury. Why? Because this is an immobile child. How come he sustained a fracture? How come he sustained an injury to having fracture? So he's an immobile child having a fracture is unlikely. That's why you are suspecting a non-accidental injury. Which one of the following should be considered for DNR? They are asking. Do not resuscitate with DNR. Here is a junior doctor who is asking about a patient who has a metastatic cancer and is dependent for activities of daily living. So DNR is a medical decision. You make it. You need to involve the patient and tell him we are placing you on the DNR. If he doesn't agree with you, then he has the right to take a second opinion. If the second opinion also says that DNR is the right thing to do here, then you will be doing the DNR. When can we choose rib fracture? Is there any keyword in the question? Rib fractures are very sensitive and specific, but it's not the commonest site of the fracture. Why? Ribs are very flexible. Rib fractures are very rarely seen in pediatric age group, especially in trauma. If you see, they will have the underlying lung injury, but there will be no overlying rib fractures at all. They're very flexible, so rarely a rib fracture will be seen in a pediatric age group. It might be because of a trauma or non-accidental injury. It is very rarely seen. 3-month-old baby with humerus fracture. Mother came, humerus fracture is there. Mother came with a partner who says rolled off of the changing table. Orthopedic surgeon has placed cuff and collar. Next best step. So you're thinking of a non-accidental injury here. Whenever you think of a non-accidental injury, basically you're suspecting here. Okay, you're not diagnosing, or you can't diagnose in an emergency department. You're suspecting. Whenever you're suspecting, involve the pediatric consultant. Pediatric consultant comes to the emergency department. He examines. If he is also suspecting a non-accidental injury, he'll admit the kid. He'll admit the kid to further evaluate, like doing a skeletal survey, report, getting a CT scan done, various investigations will be done. Then they'll be involving the police and the social services to take the action. A 13 years old came to the emergency department with significant overdose of paracetamol. The paracetamol levels are above the treatment line 4 hours. The child is a known case of CAMS who is being treated in the ED, who will be attending the ED in 2 hours. The patient is refusing treatment and wants to leave. What is the next best step in the management plan? 13 years old can consent for the treatment, can't refuse for the treatment, especially for a life-threatening. Okay. In these circumstances, what you can do is you can treat this patient in patient's best interest, that is sedate and start the NAC. He requires a treatment. If you don't give treatment, there'll be liver failure and he might lose his life. One more option, whenever there is a pediatric age group, 13 years, for example, here, if he doesn't give a consent for a life study, you can take a consent from anyone who has the parental responsibility. That option is not given. That's why we are going directly with the sedate and start NAG. If there was an option for take and consent from the parental responsibility, you can take them. Remember that anyone who has a parental responsibility, again, they can't refuse it. They can only consent for a life-saving treatment. If they also refuse it, then you can directly go and treat them under what is best thing for the patient, and you can directly treat them by sedating and starting NAC. The police bot and driver who has caught a motor traffic collision asked for your register to take a blood sample. The patient is intubated and mechanically ventilated. Your register called in the night to take your help. What you'll do? Just collect and give the sample. What the law says, you can help the police constable who has come and requesting for the blood sample. You'll just collect the blood sample and give it to them. When you do it, when the patient is unable to give the consent because of his medical condition, if the patient is able to give the consent, you need to take the patient consent before you collect the sample. If he refuses, then you are not supposed to collect the blood sample. If he gives the consent, then you can collect and give it to it. If you're not able to give the consent because of the medical condition, for example, he's intubated and mechanically ventilated in this case, you can directly collect it and give the sample. The police constable will store it, will not process it, will process only when the patient condition is stable enough to take in consent. With the consent, he'll be processing it. A radiologist from your hospital called on a Friday at 5 p.m. regarding a child with congenital hip dysplasia. The GP arranged an X-ray for the patient who is 3 years old and has a limp for the last 3 weeks. You don't have a pediatric orthopedic or what you will do next? You ask him to come to the emergency department, then you can refer him and transfer him an ambulance. You are the person who usually transfers to the other hospitals, so help your colleagues radiology department. Don't be rude with him, don't put him in the pickle, so help him and ask him to come to the emergency. Tell him to refer this patient to the emergency or shift this patient to the emergency department. You will take care. Which of the following indicates an physical abuse? Inner thigh bruises are more specific for sexual abuse. Spiral fracture in age group of 2 in the toddlers who are trying to spiral fracture of the tibia in toddlers who are trying to learn how to walk. It's and toddler fracture is common in this age group. Okay, it is not very specific for an physical abuse. Contusion of different ages on the shin becomes and more specific for an physical abuse in this case. A junior doctor says there is a red sore over the chin and he thinks it's a cigarette mark. You go and see it is an impetigo. If you're thinking it's an impetigo, treat it as an impetigo. Give him physic acid and discharge him. An agitated patient come to the emergency department with possible psychosis due to long wait. He threatens to leave. How do you restrain him? Or which one of the following sentences is right for him? You can physically restrain him, but it should be less than 10 minutes. If it is required more than 10 minutes, you need to do a rapid tranquilization. A 15 years old girl comes to the emergency department with self-harm. Patient is in depression for bullying in the school. She has plans to go on a school trip next week. Your next best step you're asking. So she is planning to go to a next trip. There's nothing suggestive of this patient is suicidal. So what you can do is you can just ask them to follow up with the camps. Because she hasn't self-harm, there might be some psychiatric injury. Child and adolescent mental health team, if you refer them, they'll treat them properly. So it becomes appropriate here. If this was not given as an option, you can refer to the GP also for the depression, what is having underlying depression. A 28 years old pregnant lady came to the emergency department with complaints of domestic violence. You raise a concern about this issue to safeguarding, then plan for and discharge. Before the patient leaves, what question you will ask her? Ask her whether she has any children at home. If there is any children at home, then you need to do a compulsory safeguarding. That's the reason you need to ask this question. A police came to the emergency department requesting the name and address of the suspect in the police incident. What will you do? There is whenever police comes and asks details of this kind of details who are involved in road traffic accident and others are involved, the general public is at help, then you can give them. You can give the personal details, how much police has asked, name, and you are just asking the name, just give the name. That should be sufficient. A 15 years old presented with a self-injury. On examination, you notice a multiple old self-injury scars. Patient denies any suicidal thoughts. She doesn't want to wait for camps. That means you can discharge her because she doesn't have any suicidal thoughts. Just treat the injuries what are there and discharge her because no suicidal ideation is there. She can follow up with the GP. If she has clinical competency, you can discharge them. While working on an evening shift, you notice a 60 years old male in the majors has suddenly become unresponsive. He has moved to research on initial assessment. You found the BM is on the lower side. He was treated with an intravenous glucose and patient recovers. You find an prescription of 10 units human actrapid in this chart. On further query, the nurse confesses that the insulin was intended for the patient in the next cubicle. The wife has just arrived to the ED, wants to know what has happened. Which one of the following statement is correct? Giving insulin which was not prescribed to the patient comes under never event. Okay, it is a never event what has happened here. Administration or overdose of the insulin or the administration of the insulin which was not supposed to prescribe. So it is a never event. You need to investigate and inform the wife what has happened. So E will be the right option. Remember what are the never events. This is the utmost the highest level of highest level escalation what you will do for never events. Okay, you arrive for a morning shift. One of the nurses finishing her shift informs you that she overheard an intern doctor, this FY2 doctor, using an homophobic language towards somebody else. What will you do? So someone is coming and accusing something else. So talk to the nurse and doctor separately, find out what has happened, tell them what is the NHS stands for. That will be the most appropriate answer. Homophobic language not supposed to be used in UK. It is strictly prohibited. Mother has brought a 9-year-old son to the ED who was involved in a road traffic accident. Patient is in hemorrhagic shock. CT scan shows and splenic hemorrhage. They are duo sorry, they are and witnesses. Okay, so this fellows, they have a religious belief that they shouldn't get a blood transfusion done. But in a pediatric age group, blood transfusion is life-saving here. They can't refuse for the blood transfusion here. So you need to inform them blood transfusion is a life-saving treatment and transfuse the blood and save the pediatric age group. Because a pediatric age group or the parents with the parental responsibility cannot refuse and life-threatening, life-saving treatment. They can consent, but they can't refuse and life-saving treatment. Two girls, 15 years old, came to the ED department with alleged rape. They say they are drunk and with an 18-year-old guy. Mostly that guy must have raped him. They do not want to involve the police. What you will do? Just refer to SARC. SARC stands for Sexual Assault Referral Center. It's a single center where a forensic examination can be done. If required, they can get an legal advice about this. They will give the treatment for contraception, for sexually transmitted diseases. They will investigate for any sexually transmitted diseases. Everything can be done at a single center. Only thing they can do is treat life-threatening medical conditions, like if some airway is compromised, you need to intubate. Those things can't be done. That needs to be dealt in the emergency department itself. An HIV patient jumped out of a bridge. The police were involved. Which one of the following is reason is contraindication for organ donation? Active malignancy is a contraindication for organ donation. HIV patients can donate to another HIV patient. Police involvement or coronal involvement is not an contraindication for organ donation. A 6-month-old baby was brought to the emergency department by his mother. Complaints of continuous crying and circumpollent burns over the limbs. The baby, the baby was with the mother's boyfriend since the morning, and when the mother came back from work, the baby was crying continuously. Suspecting child abuse. What you will do whenever you are suspecting a child abuse, just involve the consultant pediatrician. If he is also suspecting, then admission will be done for further evaluation. A 70-year-old Alzheimer's patient was brought to the emergency department with his grandson for the overdose of medication. The patient has lost his wife and daughter. He keeps taking overdose and doesn't want to live. He answers all your questions properly. The grandson wants you to treat him. What will you do? This patient is clearly in depression because he keeps taking overdose and doesn't want to live, and there is a recent history of loss of wife and daughter. So clear depression, you can, according to RCM, they clearly say that whenever there is a clear depression, you need to consider the patient is unable to weigh the pros and cons. That means he doesn't have the capacity. So no capacity is there in this patient. If anyone doesn't have the capacity, the next thing is to look out for if there is an advanced directive or this advanced decision or an lasting power of attorney. You need to look out for this. If they are having, you will treat according to what is mentioned there. If they are not having that, then we will be treating according to patient best interest. So you have to go in this sequence itself. Middle middle-aged male with history of road traffic accident comes to the emergency department, complaints of neck pain. On examination, there is no indication for CT scan. According to Canadian C-spine rule, his brother is a consultant surgeon. Demand for a CT scan. What is the most appropriate action? Firmly explain that no matter you are in consultant or someone, there is no indication means you'll not get a CT scan done. You shouldn't bow to anyone. If you are going according to the guidelines, you need to stick to your guidelines. A 73 years old is brought to the emergency department in with cardiac arrest. CPR is ongoing. Advanced directive is in place, which states DNR. So this patient doesn't have the capacity because he's in cardiac arrest. Next thing you're looking is for the AD, advanced directive, which says DNR. But the daughter wants you to continue CPR. DNR is suggested on an advanced directive. So DNR you need to respect. You'll stop. Doesn't matter what daughter wants. Which one of the following is true regarding DNR? DNR is a doctor's decision. If patient disagrees, second opinion needs to be taken. We have already discussed this in the previous questions. A 26 years old pregnant female came to the emergency department in active labor. There is no gynecologist available in the hospital. What will be the next step in the management? You can deliver this baby. As an emergency physician, you are supposed to be skilled enough to do a normal delivery in the emergency department. So deliver the baby in the emergency department. Don't refer. They might end up delivering in the ambulance itself if you refer. Chronic alcoholic arrived to the ED, was waiting in the triage, initially seen by a student nurse. 2 hours later, found dead. What you will do next? What you need to do? You can't hand over to the next consultant. Complain to the senior nurse. That's the least important thing for you. Call the police and documentation. No. Why you want to involve the police here? Document all the events and circumstances of the death, what has happened. You don't involve the police. You involve the coroner. When you don't know what is the cause of death, you involve the coroner always. Coroner is the person who will take the legal actions if required, involve the police and take the legal actions. Okay, coroner is the person who says if postmortem is required or not. So involve the coroner, he will investigate and take the necessary action. We have a 72 years old elderly has brought to the emergency department with femur fracture, who was agitated and restless. On initiation of treatment, he is uncooperative and trying to remove the IV cannula and threaten to injure the staff. What is the next best step? Next best step is to sedate and treat him. Why can't you assess the capacity? This is unsafe to assess the capacity here. This is uncooperative, trying to remove the cannula and threatening to injure the staff. You can't assess. So it is inappropriate to assess the capacity. So in patient best interest, you will be treating him. So you will be sedating the patient and continue with the treatment here. A 6 years old female came to the emergency department with bleeding from the vagina. On examination, there is blood in the underway, and she has a poor eye contact. What is the likely diagnosis? It's more suggestive of a female genital mutilation. Road traffic accident with a head injury. On examination, one pupil is dilated, another is constricted. Patient was intubated and the CT head showed massive intracranial bleed with midline shift. Neurosurgeons inform you that the patient is not for surgical intervention. Next best step they're asking. Next best step is ask them for organ donation. Ask them for organ donation, you need to involve the SNOT, specialist nurse in organ donation. So call the nurse for explaining the organ donation. The recommendation is it should be a multidisciplinary approach. What you need to have multidisciplinary approach, the doctor who is treating, the consultant who is involved in the treatment, and the junior doctor who is treating, and the nurse who is involved in the treatment, along with the SNOT, that is the specialist nurse for the organ donation, all should approach together and counsel them for organ donation and explain the patient condition. A 75 years old female came to the ED with a history of fall. Her CT scan shows an hyperdense MCA sign. MCA territory is involved. That is a medial cerebral artery occlusion is there. What is the next best step before thrombolizing? There is an lesion in the brain. So this patient might not be having capacity to give you the consent. So check for the capacity first, because brain lesions, you need to suspect there she might not be having capacity. So check for the capacity. If she has in capacity, she can consent herself for thrombolysis. If she doesn't have in capacity, then you will be doing what is good for the patient in patient best interest. No, that is not enough. if you go according to the guidelines, how you check for incapacity, if someone who is in severe depression is not able to weigh, what and all you look for? You look for understanding whether the patient is able to understand one thing. Another thing is whether he is able to retain. The next thing is whether he is able to weigh, whether he is able to communicate. So you are checking for the four things: understand, retain, and communicate. Yes, he's able to answer all the questions you're asking. Is everything he's answering. But whether he's able to weigh or not, that depends on patient. That depends on various factors. If someone has an visual hallucinations or auditory hallucinations, or someone who is in severe depression, you can assume that he's not able to weigh the pros and cons. At that time, you can, if he's not able to weigh the pros and cons, he doesn't have the capacity, and you need to treat it accordingly. Coming back to this patient, 16 years old patient with an abdominal pain came to the ED. She has an history of a multiple sexual partners. You diagnose and PID. What is the next best step? You can discharge him. Discharge her. She is in the teenage group. If she has clinic competency, she has the right to take an advice of any sexual activity, including contraception, according to Fraser's criteria. A 70 years old cancer patient having mental capacity they clearly mentioned, was brought to the ED by his daughter with abdominal pain. Her daughter has an LPA. Patient wants you to go home, but doctor is requesting for to give an treatment. What you will do? When the patient has incapacity, the LPA becomes invalid. Okay, so patient itself, you need to respect the patient wishes. So according to patient wishes, you will be sending him home. Police asked about the last night patient list. They are keen on knowing number of injured patients who were involved in the incident. You can give the information who are involved in the incident because of the safe interest of the public. You can give it. Collect the information, how much they ask for, give that much information to them. Your colleague makes and post on the social media about a case which which has a potential to expose the identity of the patient. What is the most appropriate? Discuss with your colleague, tell him there is a potential for relieving the confidential information, so remove the post, otherwise you will be in trouble. So just ask him to remove the post. Usually they'll oblige. Regarding advance decision validity, which one of the following statement is wrong? Out of all these statements, this one is wrong, because the statement need to specify precisely what treatment needs to be refused and in which circumstances this needs to be refused. It needs to be precisely specified in advance directive. A patient attendee finds an handover list in the parking lot and gives it to the receptionist, who informs you this. You're worried about the compromise of the patient's personal information. What you will do? Just inform the information governance. This is a difficult question. This is out of scope. Many people might not know this one. You need to just inform the information governance officer here. You are called to the CDU, where a 19 years old is causing a disturbance. He is heavily intoxicated and has taken an overdose of a large amount of paracetamol, requiring treatment with N-acetylcysteine. However, he does not want to complete the treatment, instead wants to leave the hospital. What you will do? You can assume this patient doesn't have the capacity because he is heavily intoxicated. Okay, heavily intoxicated persons, you can't assess the capacity. That is one more thing, because this patient will not be able to weigh the pros and cons because they are under the influence of the drug and they're intoxicated. So restrain him, call for the help, and treat him under the common law will be the right option. Mom come to the emergency department inquiring about daughter who is 15 years old and diagnosed with pelvic inflammatory disease. Regarding the patient medical condition, you can't reveal. This 15 years old has the confidentiality. So daughter has the right for confidentiality. I can't reveal this information. You need to convey to the mom. Young female frequent visitor to the ED 18 times in the last 6 months with similar presentations. Came with complaints of abdominal pain, examination completely normal, lab reports of within normal limits, diagnosed and medically undiagnosed syndrome. Patient is asking what is wrong with her. Tell her, don't hide anything, tell her that you have a medically undiagnosed symptoms, which is in short form as MUS, and no specific treatment is required. Tell her frankly, you can't hide the information, or don't try to pacify anyone. 15 years old arrives to the emergency department, looks like a stab injury of his leg. He is evasive about the cause and asks you to just deal with the wound without more questions. Which one of the following is most important thing here? Whenever there is a stab injury, you are bound with the law to inform the police, because this stab injury might, this person might be in public interest. You need to inform the police because this person might be there out who might be stabbing to others. So for that reason, you need to inform the police. So the police should be called immediately and involved. A 76 years old man arrived by the ambulance after a fall at a daycare center. His ankle is clearly causing him significant pain. However, he does not want anyone to look at it and says that he wants to go home. Which one of the following is appropriate as a first step? If you see here, the first step, most appropriate step, is to perform an capacity assessment. He's in severe pain, so he might be delirious. That's why he is not allowing anyone to check him or give him some painkillers. So perform an capacity assessment. He might not be having capacity. If he is not having capacity, you will treat it under common law. If he has capacity, then you need to respect. An elderly male, known case of COPD and chronic smoker. Patient has multiple ER visits and admissions. Was discharged only 24 hours ago. In this time in ED, he has present with shortness of breath and cough. Vital parameters stable, doesn't require any medical admission. He wants you to admit as he's afraid he can deteriorate and he's living alone. It's a good idea to do an admission. This isn't social admission, what we call it, because his social circumstances are not good. He's living alone. If something happens in the night, he may not be able to call the ambulance, then it will be a disaster. So admit him overnight, then refer him to the respiratory nurse. So because he's having a recurrent acute exacerbation of COPDs and recurrent hospital admission, so refer him to the respiratory nurse so that they can take care of him better. Two old couples came to the emergency department, 75 years old male with an upper limb weakness for a week and 33 years old female with facial weakness and lower limb weakness for 4 hours. What is the next best step? So this patient's clearly having a cerebrovascular accident. So we need to know whether this weakness is because of an hemorrhage or an infarct. Is there a tumor which is causing a bleed? We don't know. So advise both of them to get a CT scan. It's not an SLO7 question. It's more of a clinical question what they have asked here. Same scenario, the next question was, as the ER was busy, the next day the wife was brought dead to the emergency department. As ER was busy, they left. Next day they came back, brought the wife's dead body. What you will do? You don't know what has happened here. We don't know what is the cause of death. So involve the coroner to further evaluate, and coroner will give the death certificate if they see everything is fine, and on further evaluation, after evaluating, they will give the death certificate. Patient was in shock, needed femoral line for decay management. Your senior tells you to put a femoral line, but the ED going to receive 2 other cases. So consultant is going there. You have not performed central line before, but you have read about it. What you will do? They say that you go ahead and perform ultrasound guided this as a right option if you see in your MRCAM success. We totally don't agree with it. Patient safety is paramount here. You need to be frank with the consultant. Tell that you can't do it because you've never done it before. Okay, there should be someone competent enough to come and assist you to do this one while you're doing it for the first time, or you should do it someone under the guidance of some consultant who is competent in doing this procedure. So you need to tell this consultant frankly that you don't know to do this procedure, and someone else give me some other work to do, I will do that, or give me some other patient to do, I will do that, because I'm not sure how to do it, because I've never performed it, I've just read about it. So patient safety, which what they're testing you here. A 14 years old female's mother comes to the emergency department requesting for contraception. Mother can't come behalf of her daughter and ask for contraception. Daughter should come herself or along with the mother and ask. So daughter, you can assume to have a competency according to Glimic competency, and according to Fraser's criteria, she herself should come to ask for contraception. So advise mother that daughter has a competency, tell her to come and discuss about the contraception. You yourself can't come and ask in on behalf of your daughter. A 37 years old was brought to the emergency department with multiple injuries after a road traffic accident. The patient had an head injury. The neurosurgeon refused surgery as the patient is brain dead. you you break this bad news to the family, they don't want to believe the diagnosis, what you will do? Again, there's a brain dead patient, good candidate for organ donation, and involve the snod nurse. They're good at counseling this patient, informing what is going on, at the same time convince them to get, please mute, at the same time convince them for organ donation. Studies have shown that involving snot increases the organ donation chances of more than 50%. That's why always involve the snot. A Somalian girl bought by grandparents complains of pain, abdomen, eye contact is there but not social. Nurse says blood is found on the underwear while undressing. Clear-cut history of female genital mutilation. Whenever you are suspecting female genital mutilation, police needs to be involved here. Okay, it's not issue of not issue of safeguarding. Police needs to be involved whenever there is an female genital mutilation. We'll go with the next one here. A 2 years old with an sexual abuse. Which site is specific for a non-accidental injury? Non-accidental injury, it is more inner thigh. If you're saying those are more specific, what you need to suspect of non-accidental injuries. Okay. We have a 15 years old girl presents to the ED with self-harm. Presents to the ED with self-harm to the left arm here. She is feeling much better now, has no suicidal ideation, and is happy to go back to her family. On examination, superficial inside wounds which are clean and closed. You have noticed multiple scars over the wrist. Next best step. There is clear indication by this that she has attempted multiple times for the suicide. But right now, she has no suicidal ideation as such. There's no suicidal ideations at all. Then what you can do is, you can advise her to follow up. You can discharge this patient and advise her to follow up. So remember that anyone who has come in with an overdose or has come in with a self-harm, the first thing what you will be thinking, anyone who has come in with a self-harm, first thing you need to see, if I discharge this patient, whether the patient will commit suicide or not. No, the patient will not commit a suicide. Then you can discharge this patient with an arranging and follow-up for the underlying mental disorder to be seen or dealt with. If there is chances of suicide, this is basically we do a sad person and scope, but here they are given directly that there is no suicidal ideation. If there is chance of this patient committing a suicide, then you need to admit this patient for further psychiatric evaluation. Admit these patients. Why not sexual abuse? If you're asking, in this case, it is more of a Somalian girl where it is a ritual to do it that goes in favor of it, and only blood is found, and this is a 6 years old, all girl they have just mentioned, age is not mentioned, all that parameters if you keep in mind, it is not in sexual abuse, it is in female genital mutilation what you need to think about, because of the country of origin what they have given. A 20 years old female is brain dead following an assault in the prison. She has a significant past medical history of HIV. Been living in UK for last 8 months. There is no next to kin. She may not be eligible for organ donation as she is living for only less than 12 months. If she is living more than 12 months, yes, that is an inclusion. So there is an exclusion group. Anyone who is under 18 years old or under 18 years, or anyone who is under Mental Capacity Act or Mental Health Act, anyone who is a visitor who has just come to visit the UK, or people who are living in UK for less than 12 months. Okay, less than 12 months, or who are less than 18 years of age, or who are visitors, or who are under Mental Health Act. All these fellows are exempted or excluded from the organ donation. Others are assumed that they are included in the organ donation group. They're asking, a senior consultant asks you to do an audit for a lower back pain patient presents to the ED. Their medical records, including information regarding the patient's religion, is there. Which is the breach of which of the following act? Caldicott is there to protect your data. Okay, so the information, the personal information like age, sex, they are there to protect. Data Protection Act is the one which protects against the religious or ethical ethical documents what they have recorded. Human rights from emergency point of view include the adult safeguarding. So here it is a Data Protection Act which is being breached here. Okay, Data Protection Act is the one, your religion, your ethnicity, your sexual orientation, everything is included in this. Isn't proper to shift the patient to the ICU is still not announced brain death? No, according to the NICE guideline, if you go before you do this, is clearly they are not not a candidate for surgery. If this patient is not a candidate for surgery, next thing, not a candidate for surgery, that itself implies that you're going for an palliative care. Before you place to an palliative care, you need to discuss with them for an organ donation. Before you shouldn't, or you should never do an brain stem reflexes, or you shouldn't admit to ICU before you discuss for an organ donation. This is clearly given up in the NICE guidelines. Their guidelines itself for organ donation, how to go ahead. According to the guidelines, we are telling this. A 4 years old child was brought to the emergency department by his mother. A mid-shaft humeral fracture is found. Which one of the following indicates that it is not an accidental injury? It's a very clear-cut non-mobile child. Similar question we have dealt with it. A 60-year-old male who has met with an RTA came to the emergency department with life-threatening injuries. He's a known case of HIV patient. The wife says that he always wanted to donate his organ. Which one of the following is a contraindication for organ donation? Out of this, we know this is not a contraindication. We know HIV positive is not a contraindication, discussed in the previous question. Out of these two options were the confusing one. The right one is the renal. With N1 suggests it is spread to the node. Whenever there is an active cancer which is spread to the surrounding areas, it's a clear contraindication for organ donation. What about melanoma or any hematological cancer? If they are in remission, it is not a contraindication. Okay, if they are not in remission, if it is an active hematological malignancy, then it is a contraindication. As 45 years old, brought to the emergency department with history of assault, along with an 15 years old who smells of alcohol. CT scan shows an intracranial bleed which requires an hospital admission for the father. Regarding son, we don't know what has happened. Whether the son has assaulted the father, or son was why he's drunk because he's underage, below 21 years, not supposed to get an alcohol use. So we don't know what is going on here. So admit the 15 years old will be the most appropriate thing. Social services, we don't know what is happening. Social services is to protect him. His son is not injured at all, so we don't know what is happening. So best thing is to admit any underage person who is alcohol intoxicated. You tend to admit them. An infant or a child was brought to the emergency department in cardiac arrest. The child is in rigor mortis. Rigor mortis means that stiffness has developed. That means he's dead since long time. There's no point in resuscitating. The mother wants you to resuscitate the child. What you will do? Withdraw the CPR and explain the mother that the child is dead. Nothing can be done. Explain clearly to the mother. Middle-aged female present to the emergency department with seeking help for cocaine addiction. Husband with parental responsibilities at home with their child. Next best step. Children's safety is important. She is an addict. Where are children? Children are with husband. So you can break the confidentiality of this female here in interest of these children and inform the husband about the addiction so that they are protected. You are taking care of a patient who has multiple stab injuries. Police is asking for the information of the incident is ongoing and risk for general population is there. So clearly you need to give the information. What is the next best step? Name, address needs to be given. You can give it, we are dealing with it. What about injury details? Can be shared with the police here. Yes, injury details like it is a stab injury, it looks like a knife, or it looks like a stab within some other object. That is important for the police so that weapon used to commit this crime they'll come to know. So you can give the injury details also in interest of in public interest. You can break it. Why not hospital child protection? If you're talking about this hospital safeguarding, if you're talking about, or you're asking, these kids are not in the hospital, they are at the home. So at the home, who has the accessibility? Their husband, because in the question they said husband with parental responsibilities at home. That's why we are not involving the police, not involving the hospital people to do and safeguarding. If they were in the hospital, we would have involved them. The next best step they're asking, so husband will be informed. Later on, you might send the social services to the home and see how is the situation. Accordingly, they'll take the action. But immediate next step is the safety of the children. So you need to involve the husband. Here, this female has the rights to go out or get discharged from the emergency department. Then she might go to the home and children might be addressed. That's why we are informing the husband first. Elderly female is a known case of liver body dementia brought to the emergency department by her husband with complaints of choking. As ED was busy with long wait time, patient left, next day was brought dead. Again, it is a similar, different scenario what they are given. We will refer to the corona because we don't know the cause of death here. Elderly female, past medical history of recurrent recurrent TIS presents to the emergency department with right upper and lower limb weakness, which was noticed 2 hours ago. Patient seems to have capacity, refuses the thrombolysis and wants to go home. What you will do? Here, the thing is, she is having right and upper limb. It isn't severe what is happening. There is a brain injury. Okay, so basically, to put it in a very layman's term, there is a brain injury. So brain injury can happen with your decision making. So we don't know whether this patient is having an capacity or not. Seems to have capacity will not help you. You need to do an official assessment. So you can ask your senior to do an official assessment of the capacity. So assess the capacity because there is a brain injury. You are suspecting there might not be capacity. So assess the capacity will be the right option here. A middle-aged male with history of road traffic accident comes to the emergency department, complains of neck pain. On examination, there is no contraindication for CT scan. There is no, indication for CT scan occurrence in the secondary spine rule. His brother is this we have dealt already. Brother is an surgeon demands for a CT scan. What will be your most appropriate? Explain him firmly CT scan is not required. There's no indication, will not be doing the CT scan. GP referred an alcoholic patient to ED and has emailed to ED doctor the details regarding the patient. Patient requests to see the email, what GP has communicated with you. You need to refuse this because this is in confidentiality between you and another doctor or another medical professional. This is according to GMC, what information patient will be able to see in the records, coded information, free text, letters, and documents, not be able to see. Administrative talks, communication between the practice staff. Here is the communication between the GP and you, between the GP and the emergency doctor. So you need, this is a confidential information between you both doctors. So you can refuse this saying it is confidential information. A paramedic has called for advice on a baby who is dead in his home in his cot. What should be done? This baby should be brought to the this baby should be brought to the emergency department because various investigations needs to be done. We need to find out the cause of death. This is known as sudden unexpected death in a child. Okay, this thing you need to get this child back to the emergency department because it needs to be evaluated. Though this baby is dead, various investigations like why this baby is dead because of a metabolic disorders or a non-accidental injuries, those things needs to be evaluated. That's why you need to get this baby to the emergency department. So that completes our 4 classes, which we have dealt almost more than 650 questions, what we have dealt. So we have completed all the recall questions which we had. Most of it we have it. Okay, around in each diet, around 165 to 170 questions we have it, which we have dealt it. The repeated questions we have deleted and we have just dealt. We have deleted the repeated questions so it doesn't become fewer there in between. So we have completed all the recall questions. All the best for your examination. For our regular batch, we'll be meeting you on the mock discussion, which will be on the 11th. Please go ahead and give your mock exam at least before 10th so that we discuss on 11th. Those questions what we are discussing are important questions. Mock, those questions can appear in the examination. Similar questions can appear in the examination. The mock is designed which reflects very much similar to actual exam. So please give your mock exam. CWEC group initially will start management is an adrenaline what we'll be doing. If you have any questions, queries, when can we ask? You can ask in the group. Which part is more important to review. Everything is important. They can ask you, there are 180 questions. So don't just say environmental emergencies are not important. Questions can come from environmental emergencies. So you can't skip anything else. If suicidal ideation, rather admit, can we do an urgent camps? Yes, you can do an urgent camps if they are coming to an ED department. But if it's taking a very longer time, you'll go ahead and admit them. So it takes, you need to weigh which one is more appropriate. Urgent camps referral will be the most appropriate than directly admitting them. If they are ready to come down to the emergency department and review this patient, that will be the best option to select. Any other questions you can type before we stop this session? Okay, fine. We'll stop here. Thank you, everyone.
Thank you.